Who's the class rep?
Rep or prep?
Yeah.
Rep, president?
Whatever. Who speaks for you?
Vinny.
Vinny. Is everybody here? No, don't tell me what you believe. Tell me what you know.
I love that. Chiracana.
Somebody. Who is missing? Nobody's missing? Okay. All right, so I switched the schedule around because we're supposed to do EKG first, right? Then I realized that what's the point of doing EKG when I can use the congenital heart disease lecture to solidify what we did last week. So we can use the congenital heart disease lecture to get some practice on what we need while we learn new stuff. Okay? Unless you're going to be in neonatology and pediatrics, the first quarter of this lecture is FYI. You just need to know it. You don't need to pay attention to the complicated pathophysiology. If you can understand it, it's good, but I won't be testing it. Okay, I'm an adult physician. All right, I take care of adults. Okay, so, congenital heart diseases, right? Why is it that when it's raining, nothing works right? Why isn't this one working? I hope it's not. All right, so in order for you to understand congenital heart diseases and how it presents, you need to be very clear on fetal circulation. There is a lot of difference between fetal circulation and circulation of the baby. A lot of changes. And that is understandable because in the womb, the lungs are filled with amniotic fluid, not air. So somehow, the blood that is destined for the lungs has to be diverted to the placenta, okay? And there are vessels that are responsible for that. So let's take it from here. So you have the baby getting everything, the fetus, getting everything it needs from the placenta, right? Okay? So, the placenta vein carries blood from the placenta, right? And joins the inferior vena cava, right? And all of that blood end up in the right atrium, right? And right ventricle, right?
Yes.
And then from the right ventricle, it's supposed to go to the lungs, but it doesn't. Instead, it goes from the pulmonary artery into the aorta through this ductus arteriosus. Just the Latin name for arterial duct. Okay? And then from the aorta, it now goes back to the baby through the placenta arteries, and the baby gets what it needs. Now, blood still goes to the lungs, because the lungs get their own tissue, right? And even through the pulmonary artery, some blood still goes to the lungs, even though the lung is filled with fluid. That is a perfect VQ mismatch, right? Right?
Yes.
Okay. So the blood that returns from the lungs still return through the pulmonary veins into the left atrium. And some of it is now shunted. I'm sorry. It goes to the left atrium and then goes down into the left ventricle and goes out through the aorta. Right? In addition, so that is the first thing, right? The ductus arteriosus. In addition, blood from the right atrium is shunted across to the left atrium, okay, through the foramen valley, okay, because we know that blood is not going to go to the lungs, so the body makes every effort to shunt the blood from the right side to the left side as quickly as possible. So it happens within the heart through the foramen valley, right? And it happens outside of the heart through the ductus arteriosus, okay? The vein that connects the umbilical vein to the inferior vena cava, usually within the liver, is the ductus venosus. Okay? So the three structures that are very unique to the fetal circulation are ductus venosus, right? Foramen valley, and ductus arteriosus. If I ask you which of the following is an intracardiac shunt found in a fetus, and I give you ductus arteriosus, foramen valley, ductus venosus, ligamentum venosum, and ligamentum arteriosum, what is the answer? Foramen valley, because it's got to be intracardiac. When the baby is born, and blood gets oxygenated and venous return, and there is oxygenation, because when the baby is born, the vagina, the cervix, and the uterus, they form one single canal that squeezes the baby through. And as the baby is squeezed through, the chest is compressed so hard that almost more than 50% of the amniotic fluid in the lungs is expelled. So as soon as the baby's head comes out and baby takes a deep breath, the lungs, of course the baby is out, takes a deep breath, then the lungs expand. So it's like it gets expelled of all the fluid and then it now filled with air. Then there is sudden increase in the oxygen content of the blood. That sudden increase in the oxygen content of the blood is what ductus arteriosus responds to, right? And it just goes into spasm and squeezes shut. And when it squeezes shut, it becomes fibrosed. And that is what you see in adults as ligamentum arteriosum. Okay? The same thing happens to the ductus venosus, and it becomes ligamentum venosum. Okay? Everybody clear with that? Excellent. So now you see now with increased venous return to the left atrium, there is now more blood in the left atrium, and the left atrial pressure for the first time becomes greater than the right atrial pressure. So the foramen valley is closed. Because you see, the way the foramen valley works is like there is this hole right here. Imagine this is here in the left atrium, and This is the right atrium, right? This hole is foramen ovale. And on top of it, there is a flap, another tissue flap. Okay? So for as long as the pressure is higher on the right side, that flap is lifted. And blood flows from the right atrium into the left atrium. As soon as venous return increases, and there is more blood in the left atrium and more pressure, the flap closes. And now, because it stays closed and connected to the foramen ovale, it gets fibrosed and stays stuck. So that is how the foramen ovale closes. Okay, so the foramen ovale closes as a result of pressure changes. The ductus venosus and ductus arteriosus, they close as a result of differences in the oxygen content of the blood. Okay, good. This is basically what you need to know. These three structures and what they become later on. So I already told you everything I just said here. Okay. Now, congenital heart defects, bad things, cause baby pain. Ugh. That's my phone. Okay. I'll put the phone here. Be careful about that. All right. So the most congenital heart diseases are the most common and most fatal of all birth defects. If a kid is going to die in infancy, apart from sudden grief, death, most likely going to die from a birth defect that affects their heart. Okay? And because of their fatality, it is extremely important to triage these conditions. You know what triage means, right? Prioritize them for care. And one major way we do it is to classify them into cyanotic and acyanotic. Cyanotic means it turns the baby blue. That means it's really bad. Acyanotic means, yeah, baby has issues, but baby still thinking. Okay. So, what are the ones that are cyanotic? And you, once we go into them, you will realize why they are cyanotic. The most common one of them is tetralogy of Fallot. In tetralogy of Fallot, you have 4 basic defects. You have a pulmonary stenosis. In other words, the pulmonary artery opening, but it's not full. It's still like constricted. Okay. It could be at the valve level, it could be at the vessel level itself. But bottom line is the pulmonary opening from the right ventricle is not fully open. And because the pulmonary artery is not fully open, Christian, what will be the immediate consequence of that? Is it, will that cause the pressure overload or volume overload? Pressure. Which chamber will be overloaded? Right. Exactly. It causes a right ventricular pressure overload. And in order to rise to that challenge, you get right ventricular hypertrophy. Okay? And because blood cannot go through the pulmonary artery, through which the ductus arteriosus is supposed to connect it to the aorta, the Creator was very gracious. You know, they say in everything give thanks. So even though your pulmonary artery is not fully open, your right ventricle is working hard. If those kids do not have a hole in their ventricular septum, they will not survive. So generally, in tetralogy of Fallot, they have a ventricular septal defect. Because remember, without a ventricular septal defect, blood will not be able to go from the right side to the left side. Because at this level, 2 things are responsible. Foramen ovale to take the blood from the right atrium to the left atrium, right? And then the right ventricle has to get some blood and push out through the pulmonary artery. Then ductus arteriosus connects it to the aorta, right? Now the pulmonary opening is narrow, right? So the only way for that blood to go from the right side to the left side is through the foramen valley, and that is not enough. So the babies need another hole in the ventricle. And that is why in tetralogy of Fallot, you always have to have a VSD. And then the aorta is overriding. What does that mean? So instead of the aorta strictly coming out of the left ventricle, it straddles the septum. You understand what I'm saying? So if this is the left ventricle and this is the right ventricle, normal aorta comes out of the left ventricle. But in tetralogy of Fallot, the aorta straddles both camps. It sits right on top of the septum, so that both the right and the left ventricle can push blood through it. Okay? So, you don't need to memorize it. All you really need to remember is that there is pulmonary stenosis. If there's pulmonary stenosis and babies still survive, there's got to be a lot more. The right ventricular hypertrophy is really a response to the pulmonary stenosis. Okay? Then you have the transposition of the great arteries. That is a horrible situation. So this is a situation where the aorta, the vessel, okay, you see now under normal circumstances in embryology, you guys never do embryology, right? Yeah, if you do embryology, you will be amazed. Because babies come from just one cell that multiplies, develops into a tube, and from the tube you have all kind of crazy invagination, chambers get formed, stuff just start popping out. You can look at it in an accelerated fashion and you will be amazed. Under normal circumstances, both the aorta and the pulmonary artery, they develop from a single vessel. The first thing that happens is that that single vessel that was like this becomes like this, right? All it takes is just a group of cells coming from here and going from there, and they connect. And once they connect, they split the chamber into two. As they are moving towards themselves and connecting, the tube is rotating. So that at the end of the day, the vessel that started on the left ends up on the right, and the one that started on the right ends up on the left. In transposition of the great vessels, that rotation never takes place. So you end up with an aorta coming from the right ventricle and the pulmonary artery coming from the left ventricle. You see the problem? So venous blood comes to the right ventricle, it gets pumped right back out without ever making it. So instead of the circulation being in series, it's not in parallel. So venous blood goes to the right ventricle, and from the right ventricle, it gets pumped right back into the aorta. It has not been refreshed. And then pulmonary venous return to the left atrium, goes into the left ventricle, and gets pumped right back to the lungs. That is not compatible with life. You're not going to live like that. The only reason these kids live is because whenever you have this, the foramen valley stays open. It doesn't close because the oxygen level never closes and the pressure changes that it needs never really happen. So it stays open. And they have a bunch of crazy stuff, shunts that keep mixing the blood so that at least you can create some kind of connection between the right and the left circulation to help these kids survive. Right? So that is what transposition of the great arteries really is. And truncus arteriosus, yes?
Could you specify, because I missed it, you said venous blood is coming into the left ventricle and shooting out the aorta.
Yeah, right ventricle.
Right ventricle.
Because remember, Wait, no, don't memorize it, just think it through.
Yeah, that's right.
Under normal circumstances, the right ventricle pushes blood into the pulmonary artery, that's the normal thing. And the left ventricle pushes blood into the aorta. And I just told you both the aorta and the pulmonary artery, they actually came from a major vessel that got divided and it rotates. And when it finishes rotating, the aorta ends up on the left side and the pulmonary artery ends up on the right side. In TGA, that rotation never takes place. So the aorta gets stuck on the right and the pulmonary artery gets stuck on the left. So blood returns to the right ventricle, and instead of going into the pulmonary artery, it goes into the aorta. It goes to the body, and then it returns again, used up and spent up, and the same messed up blood is keep circulating through the tissues. And on the left side, blood leaves the left ventricle, it goes into the pulmonary artery, it goes to the lungs, and then the pulmonary veins return the oxygenated blood to the left side, only to pump right back to the lungs. So the circulation is going like this,
In a circle.
like that. That's why it's parallel. They're not connected. It's doing that.
How long can a baby survive?
That is what I'm telling you. The only reason they survive is because, along with all these crazy defects, there are VSDs, ASDs, the patent foramen ovale. The foramen ovale stays open longer than it should. The ductus never closes, right? So all these shunts allows the mixing of the blood. You got it?
Mm-hmm.
Excellent. Any more questions? Excellent. Now, truncus arteriosus is that big vessel that never got divided. The truncus arteriosus was the vessel that was supposed to be split into two and rotate to form the aorta and the pulmonary artery. It never even got divided in the first place. It stays as one big vessel, right? So you can imagine the kind of crazy thing you're going to have there. When the aorta and the pulmonary artery is just one big vessel sitting over the ventricles, right? So it's called truncus. That is the arterial trunk. Okay, these are crazy conditions. When I was doing neonatology in residency, I hated going to my work because you see baby in agony. They are so short of breath they can't eat. Because in order for you to eat, you have to hold your breath. The need for oxygen is so great that kids will eat. Many times they have to put tube down or put G-tube or NG-tube, whatever tube. And I'm like, these kids just took minutes into this world and look at what he or she already is dealing with. Minutes. That is a painful existence. For the parent, for the child, for the family, everybody is suffering here. You know, and I can understand why some people think that we should probably not intervene and let this kind of kids die. But who are we to pass judgment on people's quality of life? If that was what they did, Fallot would never have found a cure, the surgery that helped them live now. You know, so it's extremely important. I believe it's going to be a training experience for you to just, please, I hope none of you will ever develop into a stage where you start making pronunciation on people's quality of life. That is not your job. Look at your curriculum very well. There is no way we teach you that. You're not qualified to make those kind of decisions. No human is. Then total anomalous pulmonary venous return is the craziest of them all. Under normal circumstances, you have 4 pulmonary veins. They are all supposed to open into the left atrium on either side. Right? In this total, that's like saying this pulmonary venous return is totally crazy. That's what that total really means. Okay. Anomalous is like, it's an anomaly. I mean, like, it's not just is this abnormal, it's crazily abnormal. Because what happens is, of the 4, 3 can decide to empty into the right atrium, or it decide to empty into the, two can decide to empty into the superior vena cava, and two will go into the inferior vena cava. Just some crazy stuff going on. I have diagrams. I'm sure you see diagrams. I'm just laying the groundwork for you so the diagram will make sense. Okay? And then you have tricuspid atresia. Atresia means it never developed. Right? So the tricuspid valve never developed. Okay, let me ask you. If the tricuspid valve never developed, how is blood supposed to make it to the right ventricle? It's a big problem, right? You know the beautiful thing about this whole thing is that whenever there is this crazy arrangement, it also affects the pressure in the chambers, right? So when the tricuspid valve does not develop, that means the right atrium cannot empty. If the right atrium cannot empty, it will hold more blood than the left. And because it will hold more blood than the left, foramen ovale will never be able to be squeezed shut from the left atrium. Right? So the pressure itself keeps open. These things are so crazy that blood is going back and forth through these shunts that we're going to talk about later on. Okay? But you're with me?
Yes.
Now let me tell you my goal. My goal before the end of these first 10 slides or so is not to have you memorize how blood is flowing. No. But for you to step back and look at that arrangement and see how it will affect the pressures in each of those chambers. Because those pressures are the ones that will determine how blood flows. Okay? So that is why notice I'm not just telling you, oh, TJA, the vessels rotate, the RVS, they survive. No, I'm walking you through pressure changes that determine the flow, that will determine the survival of the kid. Okay? And then you have pulmonary atresia, the same thing, pulmonary valve, pulmonary artery valve never develop. If it never develop, how is blood supposed to leave the right ventricle? Well, the only reason it survives is because the BSD gets placed there. Right? Okay. And then you have the hypoplastic left heart. The left ventricle. The left ventricle was just never cavitated. Right? The cavity is never open. It stays like one big muscle with very little space in it. Okay? And then Epstein anomaly. In Epstein anomaly, basically what that is this is your atrioventricular rate. When the heart is being formed, like a tube, it started, and then the tube divides into two this way, and then divides into two this way. And the tissue that divides it into up and down, they are in that place called the atrioventricular ring. They are so specialized that these are the tissues that will ultimately not only canalize, but they will also form the valve cusp for both the tricuspid and mitral valve. Okay, so when you have Epstein anomaly, what happens is, instead of the division taking place at the right place to divide the tube into upper and lower, appropriately sized atria and ventricles, it happens here. It happens lower. And the implication, the functional implication, is that part of the ventricles become atrialized. So it's like Epstein moved the border. You can build the wall, right? Right? So he moved the border between the atria and the ventricle, and the direction of the move is downwards towards the ventricles. So it robs the ventricles of some space and gives extra space to the atria. So we say the ventricles become atrialized. Okay? Excellent. You got that? Excellent.
I'm sorry, what did you say was hypoplastic left was?
The left ventricle never become fully developed.
Oh, okay.
So instead of being a normal ventricle like that, right? It just becomes some crazy stuff like muscle, and that becomes a little, that's what they call it, hypoplastic. Right? It has very small stuff, right? Right. Okay. So now you see pictures of this. So these are the cyanotic ones. Baby is born blue, that is your differential diagnosis. Okay, and I have a very, I hope it's nice, of remembering it, right? And the way I think about it is, just remember hypoplastic, right? And then remember PETs. Okay? So I call it hypoplastic PETs. And I put 1 to 5 over there. So I put hypoplastic because I couldn't fit the H, right? So I put hypoplastic, and since hypoplastic means small, so I don't do small dogs and stuff like that. And I put PETs. The PET is really pulmonary atresia. P. The E is Epstein anomaly. And everything else is tetralogy of Fallot, transposition of great arteries, bronchosarteriosis, total anomalous and venous return, tricuspid atresia. Why did I put 1 to 5? Because in bronchosarteriosis is 1 trunk, right? In transposition of the great arteries, 2 vessels got switched, right? In tricuspid atresia, the 3 cusp of the valve never developed. That's why 3, right? In total anomalous venous return, there's supposed to be 4 of them opening into the ventricles, and they all open crazy, right? So you see we've covered, and tetralogy of Fallot has 4 abnormalities. So there is T1, T2, T3, T4, T5. You got that? Yeah. So if you just remember PETs, and then hypoplastic PET will help you, because this is important. People will ask you, you need to know differential diagnosis of a blue baby. Okay? Excellent. Now, when the baby is not cyanotic, those are the causes of it. Atrial septal defect, there is a hole in the heart. And usually it's in the atrial, it's an atrial septal defect, right? And then there is ventricular septal defect, there's a hole in the heart, but now it's in the, so you see, your grandma can call it hole in the heart. You can't. You have to be very, you can explain to the patient you have a hole in the heart. But if you're talking to a preceptor or a colleague, you don't say that baby was born, the kid has a history of a hole in the heart. So you have to describe it either as atrial septal defect or ventricular septal defect. Remember Epstein anomaly? Endocardial Cushing defect is the mild version of Epstein anomaly. Because you see, what I was explaining to you earlier over there is the cells that I was telling you, they are so specialized. They are called the endocardial Cushing cells. They are the ones that ensure the proper development of the atrioventricular valves and the 4-chambered heart. Okay? This defect results in failure of the endocardial Cushing to fuse and form the atrioventricular septum. So it just gives you one big chamber with incomplete separation of the atria, both of them, and the ventricle. Okay? Then you have pulmonary valve stenosis, the bone like that. Patent ductus arteriosus, when the ductus arteriosus refuses to close. Okay? And then aortic valve stenosis, and then you have coarctation of the aorta. The aorta is supposed to be a uniform vessel going all the way down. It does not even increase in size as it goes down. It's a big artery elastic artery that just conducts blood. It's the freeway through which all those other arteries come off and then take blood to their own organs. The aorta never supplies any organ directly. Nobody lives on the freeway. Even if you're walking there, police will stop you. The freeway is supposed to take you from one city to another city. You're not supposed to live there. It's not a side street. The aorta is the freeway of circulation. It doesn't directly supply anything. Nothing. Okay. All right. Coarctation is what when it gets constricted. Instead of going, coarctation is, I don't know why do they call it constriction? I don't know what they're doing. You know, there was a time we used to take pride in making things difficult for people to understand because it reflected that we knew more than them. That is the way arrogant group. It's okay to feel good about yourself, but people don't have to feel less because you want to do better. That if you have to make people feel less to feel better, something is wrong. So now the other coarcted the other. Okay, coarctation. I guess the reason they couldn't call it constriction is because it tends to happen over a good size of a good length of the vessel. If it happened like this, they probably would have called it constriction. Okay, but because it happens over a little bit of the period, reasonable length, it's called constriction. I don't know if that's the reason, but it's called coarctation of the aorta. All right, let's go into this a little more. So look at tetralogy of Fallot. I already told you what it is. This is the picture, and this picture is worth 1,000 words, right? Look at the aorta opening directly into the two ventricles, right? Look at the pulmonary stenosis. You notice that the pulmonary stenosis is subvalvular. It is not a valvular stenosis. The valve looks normal. It's the pulmonary artery itself that is undercanalized. You got that? Mm-hmm. Pay attention to that detail. And then you have the VSD. And then you have, under normal circumstances, which chamber is supposed to have more muscle? Is it the right? No. See what has happened. Baby is now born with a thicker right ventricle. Right? All these problems here. So that is tetralogy of Fallot for you. It's a cyanotic condition. The picture is clear, right?
Mm-hmm. What did you say about the pulmonary stenosis? Sorry, I missed that. You said it was the valve looks normal.
No, I said the stenosis. Okay, look at the aorta. See the wall?
Yeah.
And the space? Look at the pulmonary artery. The valve looks normal. It is the stenosis in the pulmonary artery is subvalvular, below the valve. This thickness is not normal. It's supposed to look like this. But see how thick it is. You got it? Excellent. Look at the transposition. Crazy arrangement. Aorta coming from the right ventricle, pulmonary artery coming from the left ventricle. Blood keeps going. So the blood stays red on the left side and stays permanently blue on the right side. And it keeps recycling. And the only reason these kids could survive because of this and because of this. Yeah.
Is that enough to make them survive for a long time?
That is why they should have read. This allowed them to survive for a few days, maybe a week or two. You have to fix it. This is emergency. These are kids that come from the womb straight to the OR. These are kids that when they are getting delivered, the surgeons are getting ready in one OR next door, and the obstetricians are ready, and the path is clear. They become that boom, land on that table right there. And imagine coming through the stress of being squeezed through that and then now get slashed open, and It takes hours. That's a very cruel world these kids are coming into. Everything to save their lives. If babies could watch and dictate whether or not they want to go through that, I tell you, all babies with technology and follow will say, God, return, can you take me back? Wrong entry. Yeah.
Are these things or these abnormalities detected in utero?
Oh yeah, oh yeah, oh yeah, oh yeah.
Compared.
Oh yes, oh yeah. They can detect them in the womb because that's why you always listen to the fetal heart rate. It has a normal rate, about 160 or so. You listen and the baby is going, what is going on? Where do we run into? You know, so they can, all of this can be detected. Not in details, but you can know that this baby is coming with a lot of trouble. Okay, so you can prepare for it. Okay. Now, what I want you to, yes.
So when you're in, and when you're preparing for the OR, you don't know which abnormality they have?
Not in details, no. You just know that this baby is going to have issues. Because the heart rate will be high. Baby will not be as active. It won't be the one that will kick every, how many times did they kick again?
I can't remember.
These are supposed to kick like once every 10 minutes or so. You know? And they get into all these crazy positions and the woman will go like, oh, maybe it's supposed to be that. So, you know. So, but all those movements will not take place in this kind of babies. Now, what I want you to pay attention to is Maureen, what is the normal flow through the foramen valley under normal circumstances? Thank you. It goes from the right atrium to the left. That is what it does, right? Because when the baby is in the womb, blood doesn't need to go to the lungs, so the blood gets shunted from the right atrium to the left atrium, right? Look at the direction of flow in baby with transposition. You see it's backwards, right? So do you see, this is what I'm saying to you, that I don't need you memorizing anything. Step back, understand, okay, this is TGA, flow through the foramen valley is not going to be normal. If it stays normal, then the baby will be in serious trouble. Imagine if the flow was from here to here. Baby will not survive. Because every blood that goes from here to here goes to the lungs and goes back to the lung and goes back to the lung, right? It will go from the right atrium to the left atrium, left ventricle, it goes to the lungs, return to the left atrium, goes back into the left ventricles, go back to the lungs, right? In order for this opening to benefit the baby, it's got to leak some of the oxygenated blood into that venous blood, because that is where the aorta is coming from. So the only oxygen they get is that little one that comes from there. Under normal circumstances, David, what is the patent ductus arteriosus supposed to do?
It's supposed to shunt blood away from the lungs.
Exactly. It's supposed to go from pulmonary trunk to the aorta, right? Right? That's the normal thing, to take blood from the pulmonary artery, stop it from going to the lungs, deliver it to the aorta. What is it doing here? Is the reversal. Do you see what I'm saying? So, patent ductus arteriosus, venous, flow through them depends on who you're talking about. Are you talking about a normal baby in the womb, or are you talking about a baby with TGA? So in an exam, I will tell you, in which of the following situation is flow through the patent ductus arteriosus reversed? And I'll list it. That really is to test you, make sure you understand what is going on. And if you understand it, that's a walkover for you. Okay, you don't even need to complete. Any questions? Yes? Huh? Speak up.
She's asking, can you explain how the blood is moving through the foramen valley? One more time.
How the blood is moving through the foramen valley, following pressure. It's following pressure changes. Under normal circumstances, when the lungs are filled with amniotic fluid, and blood is being shunted away from the lungs, not much blood goes to the lungs in the womb. Okay? So the venous return, the pulmonary venous return from the lung is very low. So the volume of blood in the left atrium is low. So the pressure in the left atrium is less than in the right atrium. So the normal flow is to flow from high pressure area to low pressure area. In the womb, the right atrium is a higher pressure area than the left atrium, so blood flows in that direction. But in this case, because the aorta is now coming from the right ventricle, this is a venous side with a lot less pressure, and blood is now going to the lungs. The left ventricle is now pumping blood to the lungs with a pressure head that is meant for the aorta. So that gives you way more pressure on the left than on the right, and that is what determines the flow of blood through that reverses the flow. You know. Okay. And by the way, let me tell you something. There are times I do this. It's for your own good. There are times I will harass you. I hope you don't have thin skin. If you have thin skin, you will fall out very quickly, because healthcare profession is a hierarchical profession. I'm not a very mean person, but I need you to be tough. And so there are times I will speak to you and you'll be like I just told you, speak up. There are some times that I will ask you to talk to you like that. But it was deliberate. I'm not trying to hurt your feelings, but I have to toughen you up a little. Okay? Yeah.
For this abnormality, how come VSD doesn't form and then the other parts VSD form?
Well, the thing about it is, it's an anomaly, right? It's an abnormality. The reason the baby survived, some babies have more grace than other babies. So they have VSD, they have ASD, they have patent endometriosis. In this case, a VSD will help. And sometimes it does happen. It's just that most of the time, you don't see a VSD. Okay? So, the natural shunts, the reversal of the natural shunts is sufficient. And babies do survive. As a matter of fact, one of the emergency things they do is to create a VSD. Yeah. They put a balloon, burn a hole through it, and inflate. And create the VSD. Yeah.
How come the foramen valley doesn't close, which is normally the pressure from the left ventricle?
Because remember, I told you that if you are in the right ventricle and this is the left ventricle, the mechanism of closure of foramen valley is just a flap that sits over here. For as long as pressure is higher in the right than in the left, that flap lifts, right? Now, when these kids, in fact, look at it, it's there right there. So you see, that is a little flap over itself. Whenever, under normal circumstances, when pressure is higher in the right atrium, it goes like that. But when pressure is higher in the left, that closure does not happen, and it keeps the valve open. The precise mechanism, why? Because it's a flap. What you'll expect under normal circumstances is that the higher pressure in the left atrium should actually close it. But somehow it didn't. Right? Somehow it didn't. And I don't think we really know. You know, for the doctor's arteriosus, we know it has to do with prostaglandins. Right? But right now, it's not well known. If you read any book, there may be, in fact, I can look into that. I've never really thought about it. Well, that's not normal. The reason about it is that once there is these anomalies, all kind of crazy shunts develop. Flows get reversed. That's really what I need you to know. Okay? Good. Is it good? Look at truncus. Right? So under normal circumstances, this is a truncus arteriosus that is supposed to give rise to aorta and pulmonary artery. But you see, the division never made it. Right? So you find the left and right ventricle opening into a common trunk. Okay? And then now, so the lungs and the aorta are receiving exactly the same mixture of blood. Okay? And then, so you can imagine that means the valves never really get formed here, right? Because this is a continuous chamber. This is clear, right? Okay. Look at this crazy total anomalous pulmonary venous return. Crazy venous return. I mean, seriously, look at that. That's the pulmonary vein. They're supposed to open individually into the left atrium. See, two of them join, and then they travel through the heart to go open into the superior vena cava. And this is what happens 50% of the time. And then 20% of the time, they open into anywhere in the heart. And then 20% of the time, they actually open into the inferior vena cava. You understand what I'm saying here? And then the intracardiac one is the craziest of them all. When the pulmonary veins actually drain into the coronary sinus. You know, so right side coronary sinus opens into the right atrium and oxygenated blood reaches the left atrium only through the ASD from the right atrium. So you see this crazy thing. If you like, you can memorize the image. I don't need you to memorize it. I just need you to use it to understand what you mean when you say 50% of the time is supracardial. And when you say 20% of the time is infracardial. Okay? So this is what is important. The diagram is explaining this. Okay? Yes?
You said the cardiac was when the pulmonary veins connect to the
Inferior, yeah. That is the infracardiac. Infracardiac. Below, infra means below. So below the heart into the inferior vena cava is infracardiac. Above the heart into the superior vena cava is supracardiac. Cardiac is when it goes into the coronary sinus within the heart. Okay? And the commonest one is supracardiac. You're good? Mm-hmm. Excellent. Look at tricuspid atresia. This is where the tricuspid valve is supposed to be. Do you see any opening there? There is no opening. So blood now has to go. All the venous return that was supposed to go into the left ventricle, they all now go into the left atrium, right? And then they all end up in the left ventricle. And because no blood came into or very little blood came into the right ventricle through a VSD, right? The pressure in the pulmonary artery is so low that it creates pressure difference between the pulmonary trunk and the aorta that allows blood to shunt right through that patent ductus. Right? You follow me? You did it one more time. Okay. This is tricuspid atresia. Tricuspid valve is absent. You could see there's no valve. Right? So all the venous return from both the superior and inferior vena cava end up in the right atrium like they should. But they can't go into the right ventricle. So they all get shunted to the left atrium. Look at the picture, it speaks for itself. all the blood now go either through an ASD or patent foramen valley. When the foramen valley stays open longer than it should, it's called patent foramen valley. So all the blood goes into the left atrium, and then from the left atrium it now goes to the left ventricle. Usually tricuspid atresia is associated with the VSD. That VSD, it is only through that ventricular septal defect, that VSD, that the right ventricle gets blood. It now pumps it into the pulmonary artery like it should. And because it's a lot less blood, ductus arteriosus stays open. And some of the blood that goes through the aorta gets shunted into the pulmonary trunk and then goes to the lungs. Right? Yeah.
And that's because the ductus arteriosus closes upon pressure.
No. Under normal circumstances, it is oxygenation of the blood that causes the ductus arteriosus to constrict. So since oxygenation is not happening, it stays open, right? And the blood flow through it is exactly what you would have expected in the baby, but now in the fetus, but now in the baby, it's actually staying open and keeping the baby alive. Okay, so you see, this is one place where the shunt ductus arteriosus is doing what it's supposed to do, and shunting blood down into the pulmonary artery. You're good with this? Excellent. This is pulmonary atresia. You see it? Look at the pulmonary artery. This is supposed to be the pulmonary artery. You see what happens? It becomes a tail of its own branches. This is supposed to be the right and left pulmonary artery. Look. It's opening into the right ventricle is completely compromised. It's not opening, it's closed. So yeah, blood comes into the right atrium, it goes through the tricuspid valve into the right ventricle. Thank God there is a VSD, and that through that VSD, the right ventricle is able to push blood into the aorta through the left ventricle, and then the aorta fills the pulmonary artery. You got it? Excellent. You see what I'm saying to you? That don't try to memorize the abnormality. Understand the hemodynamics. Okay? You see, there are two types of pulmonary atresia. One is bad, really bad. The other is okay. They'll be okay. If they carry a VSD, prognosis is better. If they are born with an intact septum, that is, it's unlikely the kid will survive. Okay? Although they can still walk through the patent foramen valley and VSD and all that, right? When there is no VSD, all the blood now has to go through the patent foramen valley into the left atrium, and now into the left ventricle, and then into the aorta, and then the aorta through the patent ductus arteriosus feeds into the pulmonary arteries. This MPA is main pulmonary artery. Okay, right. So, and SVC is superior vena cava. PFO is patent foramen valley. TV is tricuspid valve. Okay, and AOV is aortic outflow tract. Okay. Mitral valve is MV. I mean, you know this, right? I hope. Right? Mm-hmm. Good. See what I mean by hypoplastic left heart? He said, yeah, the left heart is supposed to have a lot of muscle, but not at the expense of its cavity. See what has happened here? Hypoplastic left heart. What do you think this will do?
Volume.
Thank you. The cardiac output here is going to be like 10% of what it should be. How is the kid supposed to survive with that? Right? If you look, I wrote here that this is a syndrome of reversed left to right and right to left shunts.
Good question, because the ventricle is so small, does it also increase the pressure?
No, the cavities, yeah, it increases the pressure of the little blood is pumping, right? But the volume of the blood that is leaving that per stroke volume is so small that it doesn't matter. You can spit at me with high pressure. I'm not going to take a shower in your spit. Right? Because it's such a low volume, right? Now, why did I say this? I wanted you to understand the complexity of it. So let's walk through it. Baby is born. The first few minutes, the lungs open, right? And pressure, venous return to the left atrium is high. And what do you get? You get a left to right shunt, right? And it's greater because the normal return to the left atrium, the return to the left atrium is normal because the right ventricle gets blood out into the lungs. And everything that leaves the right ventricle returns to the left atrium. But the left atrium has nowhere to put it because the left ventricular cavity is compromised. So a lot more blood flows from the left atrium to the right. So it starts out as a left to right shunt. That is how it starts. It's a left to right shunt. But see what happens. Because the right ventricle is now receiving blood technically from both the left and the right atria, the volume of blood it's pumping to the lungs is humongous. And very quickly, over months, there is volume damage to the pulmonary vascular bed. And the pulmonary vessels constrict to protect themselves. And because they constrict, the right ventricle is beginning to have difficulty pushing more blood into the pulmonary vascular bed. The right atrium is beginning to have difficulty emptying into the right ventricle, and the shunt reverses. The way blood flows through the ASD in patients with hypoplastic left heart is an index of the severity of the problem. If the lungs are already damaged and the shunt is reversed, even if you give that kid heart transplant, the transplanted heart will not survive because the pulmonary vascular bed is gone, unless you give the baby a heart-lung transplant. You got it?
Did you just describe the Basedow syndrome? Is that what you're describing?
Yes. Well, I think it's very much those questions. You got that? Okay. So, this is a reminder for you to step back and retrace this. When is it a left to right? When is it a right to left? Look at your Epstein anomaly, right? You see where the valve ring is supposed to be? Right? And see where it is. So half of the right ventricle is being made the part of the right atrium. Okay? There is something interesting about Epstein anomaly that I want you to know. So it's an Epstein anomaly of the tricuspid valve with atrialization of the right ventricle. Also associated with ASD in 75% of the cases. in these caves, you have a wide splitting of S1 and S2. Right? So, very good. Why is S1 split? Yeah, I mean that is what the split is. Give me the mechanism. What is the hemodynamics? S1 is as a result of the closure of tricuspid and mitral valve, right? Under normal circumstances, which valve closes first? The mitral valve closes first, right? And tricuspid closes later because of the pressure differences. So why is it widely split here? Thank you. More blood because the tricuspid valve closes even later. Because remember, the reason the valve closes under normal circumstances is because the right ventricle and the right atria are of equal sizes. Volume of blood is right about equal above and below, and the right ventricle squeezes. And once enough blood is through and pressure is increasing in the right ventricle greater than the left right atrium, that squeezes the valve shut. Now look, there's a lot more blood above the right ventricle. How is the ventricle supposed to lift this cusp with all this volume on top of it? So it closes even later. You got that? So that gives you a wide splitting of S1. Now, why is there a wide splitting of S2? Wendy? S2 is as a result of the closure of the aortic and pulmonary valve. Why is there a wide splitting of S2? Under normal circumstances, which one closes first? Well, just tell me, which valve closes first? Is it the pulmonary or the aortic? Okay, aortic closes first, right? Pulmonary closes later. But now, see, why do you think there is a wide splitting of the second half sound? Exactly. The volume of the ventricle does no longer determines when the pulmonary valve closes. The atria contributes to that. So blood has to go through it for even much longer until pressures equalize and then it closes. And because of this crazy volume into that right ventricle, you have an S3. So you have a widely split S1, a widely split S2, and an S3. That creates 5 component heart sounds. You have to really hear that on echo to understand it. That 5 component heart sounds is what is called the quadruple or quintuple cadence. So when you listen to the heart, you don't hear lob drop. You don't even hear that will have suggested the widely split S1 and S2. You hear things like it's not a normal, it's heart sound you're hearing, but it's sounding like automatic right? It's called, you will need to, that is why I'm going to revise your physical diagnosis curriculum to bring some cases and create some sounds for you to really appreciate what this thing is. Because the beauty of it is when you feel it and you hear it, you'll never forget it, right? So that is called quadruple or quintuple cadence. Now it could be just widely split S1 and S2. If it's been going on and the volume is already distending the right ventricle, you have an S3, right? So it could be a quadruple or quintuple. Quintuple is 5 components, quadruple is 4 components, okay? Cadence, because it's no longer a sound, it's like music, right? You're good with that? Excellent. So this is what I was explaining to you earlier, just to help you remember these cyanotic conditions, right? That is a cyanotic baby right there. Why? And you notice that the cyanosis is usually, well, let me just, cyanotic heart disease account for about a third of the cases. Why do they look blue? Because reduced hemoglobin is more than 5 grams in circulation. You're not supposed to carry more than 5 grams per deciliter of reduced hemoglobin in circulation. Okay, but because of the conditions of this baby, the oxygenation is less, so they carry more than 5 grams. Once it's more than 5 grams, the baby will be blue. Or hemoglobin oxygen saturation is less than 85, the baby will be blue. Okay, and how do you tell
He has a question.
What is reduced hemoglobin?
hemoglobin that has lost its oxygen?
Okay.
Yeah. Oxidized hemoglobin is hemoxy. Hemoglobin with oxygen. Reduced hemoglobin is hemoglobin that has lost its oxygen. Okay, so all the hemoglobin in the venous return is reduced hemoglobin. All the hemoglobin in the arterial trunk, aorta, are all oxygen hemoglobin. Yes, sir.
So you mentioned the hemoglobin with the cortisol. How do you do the capillary increase? How do you measure that?
You send blood to them. All right. Now, cyanotic heart failure. Okay, I was saying to you that cyanosis, notice I say central, right? Because you can be cyanotic because of peripheral vasoconstriction in cold areas like Alaska. I just broke your phone, man. I should have put it on. Okay. Now, in cold area where there is vasoconstriction as a result of cold, blood flow through the periphery is stagnated, right? And as a result of that, the tissues, they over-extract oxygen from the hemoglobin. When flow is slowing down, we call it stasis. So you can get cyanosis in the extremities because of hemostasis as a result of vasoconstriction, right? It's not because you have cyanosis or congenital heart disease. That cyanosis that you get as a result of slow flow called stasis, leading to the tissues to take more oxygen from a particular volume of blood flowing through them. That cyanosis is called peripheral cyanosis. So cyanosis is not just because the baby has blue hands and blue feet. No, that is peripheral cyanosis. It is peripheral cyanosis because the baby has blue lips. No, it is central cyanosis. Thank you. It is central cyanosis because the baby also has blue lips. That means it has nothing to do with flow. It has to do with stasis. If it's only in the extremities, it is a peripheral cyanosis. That is not a sign of cyanotic heart disease. So if I tell you the following are the features of cyanotic congenital heart disease, central cyanosis, or I say peripheral cyanosis, tachypnea, tachycardia, and then peripheral cyanosis, you know that is not true. In congenital heart diseases, cyanotic, you get central cyanosis, not peripheral. You remember that? Good. Don't forget it. And whenever you have chronic hypoxia, you develop what is called digital clubbing. You talked about this in your physical diagnosis class. Okay? I will talk about the Shamrock window and all that. So, you notice that here, I just told you that these kids end up with heart failure. How they get to heart failure is complex, it's complicated. It depends on what they have. It could be due to a right to left shunt, mixing the oxygenated blood with oxygenated blood. It could be due to common mixing, where there is no separation between the right and the left circulation, everything is mixing together. Or Or it could be due to parallel circulations, as in TGA. So, I don't want you to bother, I didn't bother, you shouldn't bother about the pathophysiology of heart failure in congenital heart diseases. It's not your fault, it's not your area. Okay? I'm an internist, I don't even know that. Okay, so just know that it has a lot to do with whatever is happening. The shunt, the common mixing of prior circulation. If you give me a specific diagnosis, I can walk you through the pathophysiology of the heart failure in that condition. Because the pathophysiology of heart failure is different in TGA than it is in tetralogy of Fallot. And it's different than it is in total anomalous pulmonary venous return. So it depends on what you're talking about. So if anybody asks you, so what is the pathophysiology of heart failure in cyanotic heart disease? That means they don't know what they're talking about. Because cyanotic heart disease, your next question should be which one? Because it's really complex. The common mixing, right left shunt, prior circulation. If you give me the one you're referring to, I'll walk you through the heart failure. Then they will back up. Okay. So how do you see? How does heart failure present in kids? Because these things you see it in children. You must recognize it. So see, leg swelling you will never see in kids, okay? Because they are not standing and going around like adults. So if I tell you common physical sign of heart failure in neonates, shortness of breath, tachypnea, tachycardia, leg swelling. Leg swelling, which leg? You know what I mean? So leg swelling, that is why I said neonate. And if I tell you, oh, common signs of heart failure in children, in the neonate, dyspnea and exertion. What exertion? Where do they go? Do they go to the bathroom or do they go to the kitchen? Do they go to work? It doesn't make sense, right? To talk about leg swelling and dyspnea and exertion, or even chest pain. And the cat tell you have chest pain. They'll just cry and they won't eat. That's it. That's all they will show you. But now if you look very well, they have difficulty breathing. And when they are being fed, they sweat. Can you imagine what you and I take for granted? How many of you run? Jog? You jog, do some kind of exercise, right?
Yeah.
I want you to think for a minute how you feel when you go for your exercise and you jog. You're tired. You're sweating. That is how these kids feel every time they eat. How many times do they eat? Almost a dozen. Can you imagine what your life will look like if you have to experience what you've experienced when you exercise 12 times a day? They sweat when they eat. That's why they don't like to eat. So you have poor feeding. And of course they don't thrive. They don't grow like the rest of their mates. When you examine them, they're tachypnic, they're tachycardic, they're dyspneic. So they're in respiratory distress. Tachypnea and dyspnea together is what we call respiratory distress. Okay? Then they have abdominal distension. And if you look in their back, you see the baby up, and you look at the back, that is where the edema is. So it's a sacral edema, not pedal edema. Dependent edema. Okay? It's called dependent because it goes in the dependent side of the body. Okay? Because babies on their back, baby in the back. The reason it's in the feet, in the adult, is because we are not feet. So it's really a dependent edema. But the position, the location depends on the position of the person. Okay? Of course, when they grow a little, they can tell you, oh, well, you can watch them. When they're playing with their kids, they are the ones that they don't play for a long time, right? They throw the ball twice and then they're done, right? They have autopia. They don't like to sleep lying down. They sleep sitting up, okay? They wake up in their sleep, short of breath. They have abdominal pain because of hepatic congestion. You know, you see how close the liver is to the inferior vena cava? So when you have venous congestion, the liver gets congested too. The liver itself does not have pain fibers, but the capsule of the liver has pain fibers. So when the liver gets congested and the capsule gets stretched, they get pain in the abdomen. Okay? Then when they're old, and then they have indigestion because their GI mucosa is congested. I explained this to you in pharmacology somewhere, right? Did I? When you have heart failure, you have congestion of the GI tract, edema of the GI tract basically, and that increases the distance that the food has to travel to be absorbed, and the enzymes have to travel to get to the cavity. So digestion does not go on well. It's slow, sluggish, so kids vomit old food, right? And then you have jugular venous distension because if the heart is failing, that means there is forward flow is impaired, so blood flow, the venous flow backs up, and you see it in the neck. Okay, these are signs of heart failure. We'll talk about heart failure down the road. This is just to get your feet wet, like appetizer. Okay, this is a little bit more illustration on differences between central and peripheral cyanosis. The mechanism in central cyanosis is diminished arterial oxygen saturation, whereas in peripheral cyanosis is diminished flow of blood to the local part. Where do you look for it? Peripheral, usually on the skin only. Central, you look at it for it on the central mucosas, tongue, lips, cheeks. Because the hypoxia of peripheral cyanosis is not a true hypoxia, you don't get clubbing, right? Central cyanosis, babies are warm. Peripheral cyanosis is usually in cold. If you apply local heat to peripheral cyanosis, the color changes. That does not affect central cyanosis, because when you apply heat, you cause vasodilatation. Once you cause vasodilatation, flow increases. So peripheral cyanosis will improve with heat, but central will not. Good exam question. Pay attention to that. Another thing that happens when you have hypoxia is the body increases the red cell mass. So hemoglobin and red cell count increases. That is called polycythemia or erythrocytosis. Okay, do you guys talk about that yet?
Yeah.
Good, excellent. Okay. How do you recognize what is digital clubbing? That is what it is. You lose that angle there. And you can grade it like that. Grade 1, 2, 3, 4. Nail blade fluctuation is the first thing. Then you lose the angle between the nail bed and the nail fold. Then increase convexity of the nail. This is so difficult to see in kids. So this guy, Shamrock, came up with this, that under normal circumstances, if you do this, you can have the Shamrock window, you can look through it, I can see all of you. You should be able to see me. That hole there, when you put your stuff together like that, is Shamrock window. When you have digital clubbing, you don't have Shamrock window. You lose the Shamrock window. Okay? How do you manage it? Well, first you have to diagnose it. Management means diagnosis and treatment. Okay? So when I use management in most of my slides, I'm talking how do you diagnose and treat it. Diagnosis, well, electrocardiography will show you the enlargement and all this crazy stuff. Because remember, when the chamber is enlarged, it has more muscle cells, the more the muscle cells, the greater the voltage and electric forces that it can generate. So it will reflect on the EKG. Then you have to use echocardiogram to see the flow. Where are the leaks? Back flow, forward flow, unusual flow, crazy flow. And sometimes you have to do cardiac MRI. And believe it or not, they do cardiac catheterization to see which vessel is maybe affected, to make sure that you don't go fix the BSD and find out the coronaries are dead. Right? You do cardiac catheterization to just make sure you walk the baby up carefully. On the emergent basis, you give them oxygen, you give them diuretics to decongest them. You always give them prostaglandin because in cyanotic heart disease, you need prostaglandin to keep the valves open. Okay? And that is why when we see kids that have patent foramen ovale and they don't have cyanotic heart disease, they just have a patent foramen ovale, you give them ibuprofen, indomethacin, NSAIDs to block prostaglandin production and cause declusion. Okay? And then you do all kind of crazy surgeries. All I need you to know is like for shunts, you can create shunts. That is what Blaylock did for tetralogy of Fallot. You can switch the vessels. So for TGA, you can do arterial switch surgery, or you can just repair the defects. Okay? So these are basically the kind of things that you can do to help these kids out. Okay?
Sorry, what was TJ?
Huh?
What was TJ?
You tell me. Transposition of the great arteries.
Okay.
Yeah. All right. So this is the first half of the lecture. I'm amazingly on time. Any questions? It's kind of cool. You want a break?
Yeah.
All right, go. 5 minutes. So we're going to go now to the acyanotic. Acyanotic. That means A means absence, right? Atypical, absence of typical. So acyanosis, congenital heart diseases that are not associated with cyanosis, or congenital heart disease with absent cyanosis. Okay, there they are. And I already told you why you will get cyanosis is because most of the time in the presence of these congenital heart diseases, you still are able to keep your reduced hemoglobin, which is the hemoglobin that is already the oxygen is already out, and you're able to keep it less than 5 gram %, so you will not look good. And these children are able to maintain oxygen saturation above 85, so they don't look good. These are kids that will survive till adulthood. And if they are from third world country, recent immigrants, you will see them. In the US, rarely, because we screen kids for this. Neonatal, pediatricians go into the labor room, examine the kids thoroughly, identify the kids. But there are some people that are still giving birth in birth homes in many places in the world. And those midwives don't listen to like those Egyptian midwives. They didn't auscultate. They just collect the baby, give to the mother. So kids that are raised in places like Egypt and the rest of Africa, they might have these issues, Guatemala, even Brazil, rural area in Brazil, all these islands, Aruba, all those places. You can see adults that will walk into your clinic and you will see it. That is why you have to pay attention when people have specific characteristics without necessarily stereotyping them. You use the information that they present with to make sure that you factor some things in. And you as true graduates, that is why you're here. That is why you chose this place, I hope. Because you are going to make sure that you leave this place sensitized to those conditions more than anybody else. Most of the time, it's a single lesion with a simple pathology and pathophysiology. Only two mechanisms: a left to right shunt or an outflow obstruction. That's it. All the thing we're going to talk about, they're either going to be a left to right shunt or outflow obstruction. All right? So, if I tell you which of the following conditions is associated with acyanotic heart disease, and I put a right to left shunt there, you don't have the wrong answer. For cyanotic heart disease, it's complicated. You can have right to left to right, and all these problems. But for acyanotic, it is usually a left to right. You know why that doesn't bother people? Because there is nothing wrong with the blood going to the lungs, having a little more oxygen than it needs. It's okay. Blood can go from left atrium into the right atrium. That's okay. That blood is oxygenated, is going to make the oxygen level on the right side a little higher than it should be, and that's okay. It's going to end up in the lungs. That's fine. What you don't want is a right to left shunt where you're diluting the blood that was already oxygenated from the lungs and destined for the body. You don't need that. I don't mind you taking my kid's lunch money on his way home. But don't take it from him on his way to school, then he will starve. Right? Exactly. So, right to left shunt, we don't want. That is like taking the kid's lunch money on his way to school. Right? But left to right, it's okay. A little blood, little liquid, but that's fine. Okay? So what are they? Patent ductus arteriosus. Did you see why you know why we are not supposed to eat the tree of knowledge of good and evil? Because we don't know anything that is truly evil. We are not equipped to judge good and evil. Look at patent ductus arteriosus that was responsible for the survival of children with cyanotic heart diseases is now responsible for the sickness of kids with acyanotic congenital heart disease. You understand what I'm saying? Mm-hmm. Atrial septal defect. These are things that help kids survive. Now they're killing them. Endocardial cushion defect, VSD, endocardial cushion defect, pulmonary valve stenosis, aortic valve stenosis, and coarctation of the aorta. These are all acyanotic congenital heart diseases. So we're going to start with patent ductus arteriosus. So you already know about that, what it does, all right? It's supposed to, when the baby is in the womb, it's supposed to take blood from the aorta into the pulmonary artery, right? No, you're supposed to take blood from the pulmonary artery into the aorta, right? After birth, when the baby is born, it's supposed to squeeze shut, but it doesn't. It stays open. And when it stays open, because the pressure is now higher in the aorta, it now leaks blood from the left to the right. So it's a left to right shunt, right? It leaks blood from the left circulation to the right circulation. Okay? Common etiology, prematurity with immature lungs. Rubella, And there are some chromosomal abnormalities that will be responsible for this. But the commonest one is premature lungs. Lung prematurity, when kids are born at 30, 38, 32 weeks, 28 weeks, the lung is immature, right? That creates some surfactant production problem. So, and then that creates that problem. So these are the common etiology. It's an acyanotic heart failure. How do you know, how do you recognize it? It has this wide pulse pressure. And that wide pulse pressure will give you a bounding arterial pulse. And you know, in kids, you feel the carotid, right? You don't go radial, you feel carotid.
I thought you do brachial.
And you do brachial as well, yeah. Okay? But the most important thing is that it will still cause heart failure, but they won't have cyanosis. But the murmur is an interesting murmur. It's a continuous to and fro machine-like rolling thunder murmur. So these are all the ways it can be described. Whenever you hear machine-like rolling thunder, it's a murmur that does not allow you to hear S2 because it envelopes it. So the kid will have lub, lub. So you will not be able to hear the second half sound because there is this murmur that completely envelopes it. Okay, it is called rolling thunder, it's called machine-like. And when you put your hand in the left subclavian, you can feel the thrill of that murmur because it's a turbulent flow. It's not a normal flow, right? Right. So you feel the thrill. A thrill is a palpable murmur. Okay? A thrill is a palpable murmur. Okay, I'm not talking about weather thrill. Let me tell you a story. When I was in residency, and I was in medical school, you know, I was in Nigeria. So we were on cardiology round. And there was this 16-year-old girl that has BSD. She was born in the village in the north. And then she started getting sick and short of breath, and they brought her to the hospital. And you know, in those days, we used to be like mostly men, right? And we're rounding, and this girl, it was our turn, and she was being presented. The intern exposed her completely, right? And the poor thing was sitting there. And the mother was, when we got to the bed, the mother got curious and she came around to listen to what we were going to say about the kid. So one of the medical students was asked to examine the patient. So he was examining the patient and he went and put his hand right under her left breast and says, "No thrill." And the mother just slapped him. I didn't bring my daughter here for you to be having thrills. And of course she apologized after I was explained to her, right? So a thrill is a palpable murmur. It's a murmur you can feel on your, when you put your hand. Have you felt a thrill before? Oh. Anyway, you will feel shunt, AV shunt on dialysis patient. It's exactly the same thing. Only this time you feel it when you put your hand on it. Have anybody felt the AV shunt of dialysis patient?
Yeah.
Good. Yeah, it's exactly the same thing. Only this time you feel it over the heart. Okay? So a palpable murmur is a thrill. So you always have that subclavian thrill on the left side. Diagnosis, you will see, you of course, because with this type of a thing, you will see on echocardiography. How do you treat NSAIDs to inhibit PD2 synthesis? If that does not work, after 6 to 8 weeks, you send them for surgical closure, and they can either ligate it or embolize it. It doesn't matter, whatever they do. You embolize, you throw dirt in it, or you pyro and have the ligation. Okay? Good? Mm-hmm. Excellent. Please remember, machine-like, to and fro, machine-like, rolling thunder. I don't know why they describe this stuff because I don't think you guys know what rolling thunder is. You have to grow up in sub-Saharan Africa to understand what rolling thunder is. And you will take over. Okay, so that is PDA. Let's talk about ASD. Now it makes sense for us to do this lecture after our first lecture, right? Okay, good. ASD is atrial septal defect. You understand that? There's so many types of it, depending on where in the interatrial septum the hole is, right? It could be very high in the septum near the superior vena cava. When it is like that, it is called the sinus venosus defect. It could be very close to the opening of the inferior vena cava, and when it is like that, it is called inferior sinus venosus defect. It could be right there about the center, right? When it is called the secundum atrial septal defect, or it could be very close to the opening of the coronary sinus, when it is called coronary sinus defect, or it could be right above the mitral valve, when it is called premium septal defect. Why does it matter? Why do we bother talking about inferior sinus venosus defect, superior sinus venosus defect, secundum or premium? Why? There's only one reason. Pay attention. Whenever you have mitral valve abnormalities associated with ASD, it is usually the premium defect. So we go through all this to identify premium atrial septal defect, because that particular one would, because it's so close to the mitral valve, is often associated with mitral regurgitation. Okay, so if I paint a clinical picture of ASD for you, and I'll start telling you that the first heart sound is somehow soft, right? And that there's a systolic murmur, but the pulses are normal. I'm painting a picture of ASD and mitral regurgitation together for you. You know you're not dealing with two defects, you're dealing with one. Is the premium atrial septal defect. That is the reason for classifying it like this. You got that? I mean, that is the clinical significance. Everybody clear with that? Good.
So you're saying that the primary atrial septal defect is what affects the mitral valve?
Yes, it implicates the mitral valve. So you tend to have ASD with mitral regurgitation. Okay? The only one. Everyone else, there is all of the other four, right? That doesn't matter. So a typical exam question will be either it can be I want to be complicated, I will paint a big picture for you, give you a clinical picture of both ASD and mitral regurgitation, and tell you what is the most likely diagnosis, or I will tell you which of the following atrial septal defect type is associated with mitral valve abnormality. That's the easier one. I'll give you that one in the midterm, but I'll paint a picture for you in the finals. Okay? When do you get a good?
Question, is the final cumulative?
Huh?
Is the final cumulative?
It depends on how you do. If you do well, or if all of you pass your midterm, I will only base my final on the last part. But if one person flunked midterm, your final will be completed. All right? You're supposed to be a team, right? All for one, one for all. At least that is the vision. So common etiology, Down syndrome, fetal alcohol syndrome. Those people that drink and have babies, they can predispose their kids to this. So again, it's an acyanotic right heart failure with pulmonary flow murmur. You remember I told you that you can get a murmur whenever there is turbulence. And there are two ways to get turbulence. Either too much blood flowing through a normal sized orifice or a narrow orifice and normal blood flow. Because ASD would always shunt blood from the left to the right, it increases flow through the tricuspid and pulmonary valve. So you are likely to get pulmonary flow murmurs. Okay? But what is it that is pathognomonic? You know what that word? Have you heard that word before? Okay. Pathognomonic is a word you must know. Pathognomonic means is the signature. Whenever you see that, that is present. So, wide fixed splitting of the second heart sound is pathognomonic of ASD. Okay? And you all know why, right? We already talked about that last week. Because under normal circumstances, the pulmonary valve closes later. Right? Now, with more blood coming through from the left, that ejection, it has more blood to pump, that volume even increases. Right? So that second heart sound is even more widely split. And it will not vary with respiration, because under normal circumstances, during inspiration, more blood returns to the right and less blood returns to the left. So during inspiration, there is wide splitting, right? Normally. Well, if there is ASD, it does not matter how much blood came to the right atrium or how much went to the left atrium. The ASD will equalize the pressure. So the splitting does not vary with respiration. So it's a wide, fixed split. So if I give you a case and say, 26-year-old female presents with leg swelling, shortness of breath, yada yada yada, on physical examination, she has a widely split, fixed second heart sounds with, say, a systolic murmur that is loud at the apex and softening, or a loud S1, or a soft S1. Right? Soft S1, systolic murmur in the mitral valve, and pulses are fine. You know I'm talking about ASD with mitral regurgitation. The reason I will say pulses are fine is because if it is aortic regurgitation, or if it is aortic stenosis, it will also give you systolic murmur. But the pulse will be low volume. So if it gives you a systolic murmur, and the pulses are normal, you're probably dealing with mitral regurgitation. Because only two things will give you systolic murmur in a normal adult. Either mitral regurgitation or aortic stenosis. If pulses are normal, pulses are not low volume, then it's more likely mitral regurgitation. Because if the aortic stenosis, pulses will be low volume. See that this is what we're going to be doing in your physical diagnosis subsequently. Okay, but this is where it's supposed to happen. But the way it's going right now is not the way that's not how it's happening. But I'm going to fix that little bit. Okay? To make it be what I'm just talking to you about. It's supposed to be, that's what is called clinical synthesis. You use information you know to eliminate and incriminate conditions based on what you're looking at. Okay? Everybody good with that? Excellent. Then you, because of this extra volume in the right atrium gets a little bit big, and then because it's big, it becomes irritable and can go into fibrillation. You can get atrial fibrillation. But what is incredible is that they have this thing called paradoxical embolism. Under normal circumstances, if you form a clot, Stanley, if you form a clot in the right atrium, under normal circumstances, where would that clot end up? The right ventricle, and then where would it end up? Where is it likely to be trapped? Thank you. Under normal circumstances, any clot in the right atrium is supposed to get trapped ultimately in the lungs. When there is VSD, that clot can give you a stroke. And because right-sided clots are not supposed to make it to the arterial side of the circulation, that kind of stroke is called, or that kind of embolism is called a paradoxical embolism. So if I tell you a 28-year-old college student, non-smoker, does not use alcohol, no hypertension, is brought in with a dense hemiplegia, physical examination is significant for wide splitting of the second heart sound, no murmurs. You know immediately this is a paradoxical embolism from ASD. You got that? Good. EKG, you will see, depending on where this thing is, you could see a first degree AV block, you could see right ventricular hypertrophy, you could see right bundle branch block. Remember that the,
Yeah, I want to ask something about the
paradoxical embolism,
Yeah,
yes.
you said normally it would lodge in the, towards going towards the lung, but because of this, it won't lodge there?
No, it could. So whenever, under normal circumstances, without ASD, if you form a clot in here, you and you get dislodged. Remember, a clot at a position is called a thrombus. When it breaks into circulation, it's called an embolus, right? And the formation of clot at a station is called thrombosis. The movement of that clot from its site of formation to a distant site is called embolism. So if you form a clot within the right atrium and that thrombus embolizes, it will go into the right ventricle. It's not going to cause any problem. That's the big chamber. Then it will flow into the pulmonary artery, and it will continue in that circulation until it gets to a blood vessel that is its size. When it gets to a blood vessel that is its own size, it sits and blocks it off. That is what will happen under normal circumstances. But if you have ASD, that clot, instead of going down, can go to the other side. When it goes to the other side, into the left atrium, it now ends up in the left ventricle, and now come out into through the aorta, and it could go to your head, or it could go to your kidneys. Bottom line is that you're going to end up with an arterial occlusion as a result of a clot that was formed on the venous side. Under normal circumstances, when you form clots on the venous side, whether you form them in the heart or you form them in your legs, they always get trapped in the lungs. Because remember, in the lungs, the pulmonary artery break down into pulmonary capillaries. No clot can traverse the pulmonary capillaries. You get trapped there. So the lungs is where they all end up, usually. But when there is an ASD, you can end up on the arterial side and cause a stroke, bowel ischemia, depending on what it does. If it goes to the eye, you can get sudden blindness in one eye. If it goes down, you could be severe abdominal pain, and the patient will be rolling on the floor with pain. And you examine them, there is nothing, because it's an ischemic pain. And the only clue you will have will be that wide splitting of the second. So you see why you should do a thorough physical examination of your patients, especially if you're seeing them for the first time. And every time if you're looking at them in the emergency room. Because yes, a clot from the heart can give you severe abdominal pain in somebody with ASD. You listen to the heart. Practice listening to the heart. If you're used to what normal heart sounds like, you will recognize when it's not sounding right. I want to advise you, every week, listen to your own heart sound. I'm assuming you have no heart sound. Okay, because that lobbed up, ultrasound will not, it will tell you what it sounds like in a moment, but listen to every heart you can listen to. Because when it's not right, you will see it. I mean, it's simple. It's like you see people, I know the way Lost looks every time. He's always smiling and happy. When I look at him and he's looking like, like, boss, what's going on, man? That's not you. Right? Because I've seen him over time and I know him, right? See, the same thing with heart sounds. Once you're used to them, you may not always be able to describe the abnormality, but you will always recognize them. It doesn't sound right. And that's all you need. It doesn't sound right, then you begin to do more thorough physical examination, and then you figure things out yourself, especially you, because I'm going to make sure you're able to do it. Excellent. So, if I show you an EKG of somebody with a wide fixed split of the second heart sound, and on that EKG you see first degree AV block, and I ask you which type of ASD do you think this person has, what is it going to be? Premium. Because remember that the ASD node is right here, right? And it goes through bundle of the right bundle, left bundle. So premium defects can cut off the bundle or interfere with the AV node itself. All right. So whenever ASD is associated with normal EKG, no mitral valve murmur, you don't have to worry too much about it. Doesn't mean you don't treat it, but that's somebody that will go on for a long time before they get sick. Because they will live with little mixing. You're not going to be going to heart failure. It's when you begin to shunt large volume of blood right through to the right side that you become, the volume overload the lungs and you cause problems. You're good with that?
Yeah.
Excellent. Echo is ultimately what you're going to do. You have to close this before the patients get to the age 25 or before the pulmonary artery pressure exceeds 40. Because if you don't, they will be permanently disabled. By age 25, if ASD is not treated, the increased flow to the lung damages the lung and creates that isomeric complex. But we talked about that. But I just need to pay attention. ASD, you must fix by 25, or before if it's a severe defect with a huge shunting of blood, you must not allow the pulmonary arterial pressure to go above 40. What is the normal pulmonary arterial pressure?
16 or 18?
Yeah, they're about less than 30 usually, systolic. Okay. So you don't let it go above 40. That's an indication of the severity of the problem. Okay? Now here is VSD. This VSD is the craziest thing you've ever seen. I told you about that kid that had VSD. The murmur was so loud that when you put your stethoscope above her chest, I mean, not touching it, just a little bit. You know the way in medicine, if you want to know how loud a murmur really is, if you want to grade it, one is you put your stethoscope completely flat on the valvular position, right? And you can hear it. Then you lift your stethoscope. I only leave the edge of the stethoscope in touch. That if you could still hear the murmur, and that's a significant murmur. If you lift the other end of your stethoscope and you could still hear the murmur, that is a grade 6 murmur. Right? Because that means the murmur is so intense that the intensity of it is sending the chest wall into vibration that can be transmitted to your stethoscope. Okay? VSD, if any murmur would do that to you, is VSD. And you know what is crazy? The tinier the defect, the louder the murmur. So the patient will come and you'll be like, very intense moment. This child is really sick. No, that is the one that is okay. It is the one where the murmur is soft that you worry about. Okay? The smaller the defect, the greater the gradient, and the louder the VSD murmur, and there is always a trill. Usually this is found in Down syndrome. Again, it will give you acyanotic heart failure with a loud pan-systolic murmur. Again, that murmur will obliterate. You will never hear second heart stop because it comes before it and it just obliterates you. So you hear the first, but you never hear the second heart sound. Okay? Usually with palpable trill, but it doesn't have to be there. Heart sounds are usually normal. Okay? Heart sounds are usually normal. Remember I told you about flow murmurs, right? So if you have, how would you tell, Alex, how would you tell a pulmonary flow murmur from a pulmonary stenosis murmur? Is that true? That you cannot tell, Kiara? Is it true that you cannot tell a pulmonary flow murmur from a pulmonary stenosis murmur? Thank you. A flow murmur will never affect the quality of the heart sound. A valvular defect will always give you some, will affect the quality of the heart sound. So in pulmonary stenosis, the second heart sound will be soft. Whereas if it's a flow murmur, the second heart sound will be normal. Okay, pay attention to that, don't forget it. Okay. So that in VSD, heart sounds are normal, right? Why they ask you that question? Because in VSD, heart sounds are normal. You have a pansystolic murmur. Heart sounds are normal. So that is almost looking like it's a flow murmur. But a flow murmur will never give you a thrill. Right? Flow murmurs are usually low intensity. You will never get a thrill. You understand what I'm saying? So how would you tell a murmur of VSD from a flow murmur and a valvular defect? Well, if you have a valvular defect, you will always have a murmur. Right? And your heart sounds will not be normal. It will be loud or soft depending on the kind of defect you have. If you have normal heart sounds, then you either have VSD or flow murmur. Well, if you have a VSD, you have a thrill. A flow murmur will never give you a thrill. Do you see? I'm trying to help you understand how you use this clinical information, by the bedside. So if somebody has a systolic murmur, differential diagnosis could be a flow murmur, it could be VSD, it could be mitral regurgitation, it could be aortic stenosis. How do you tell all of these apart? Well, it's simple. If it's a flow murmur, heart sounds are normal, there are no thrills. If it is a VSD, well, it's a loud to and fro murmur, heart sounds are still normal, and here is a thrill. What if it is mitral regurgitation? Well, it's a systolic murmur, but then S1 will be soft. What if it's aortic stenosis? Well, S1, S2 will be soft, and pulse will be low volume because it's on the left side. You can feel that. Are you with me? Excellent. So diagnosis, electrocardiography and echocardiography to show the chamber enlargements and stuff like that. The good news is that you can actually sit on this one. You watch it, invariably it will close by itself, but you monitor the patient. If the patient becomes symptomatic, you could start with decongestive therapy. We'll talk more about what that means. It's basically decongesting the venous system. And if that does not work, you have to send them for surgical closure. Especially when the heart failure does not respond or they're developing pulmonary hypertension. In other words, they are flooding their lungs. Everybody good with me? Right? Excellent. Questions? Endocardial cushion defect. You see, I told you about those specialized cells, crazy cells. Endocardial cushion, also known as atrioventricular cushions, are the embryonic cell. They transform the common atrioventricular canal into the four-chamber heart that you have with interatrial and interventricular and atrioventricular valve rings. See what I was telling you? A single canal. A single canal. These cells just start multiplying start multiplying, and the first thing they do is separate it to right and left, and then separate it to up and down. And it's an amazing process when you watch on video how these cells move. So the right atrioventricular canal give rise to the right atrium and the right ventricle, while the left give rise to this. They just already told you about this, right? That's what I was trying to draw on the board. Remember? Okay. So this is what endocardial cushion defect looks like. Instead of a 4-chambered heart, you have this crazy thing here. I mean, the heart becomes like the heart of a frog or something, right? This is not a mammalian heart. This looks more like the heart of a reptile or something, right? This is not how human heart is supposed to look. But this is, because now this heart is just a single chamber of both above and below with only one valve. And all the vessels open into this common chamber. See how crazy it could get. ASD, VSD, mitral and tricuspid regurgitation can coexist in endocardial cushion defect. So this is really bad stuff, okay? And the thing about it, it's not always this bad. It could be better than in some places than others. You see here, there is almost complete separation of the chambers, but instead of having 4 valves, you have only 2. Here, even the separation is not complete. This is the worst kind. Okay? Complete, transitional, partial, normal. This is just to let you know that it's not always this bad, right? Here, you can't even hear heart sounds. It's just... What the heck? Yes, Karen.
So this picture is saying that they have just one atrium and one ventricle?
Yeah, it's a common chamber. Yeah.
As far as like the aorta.
Yeah, what about it? Yeah, where's the aorta? That's the point. All the aorta is somewhere, but of course they have the aorta because they are born cyanotic. So it's not just, it's difficult to position the aorta with this kind of, in a picture with this kind of situation. I'm sure the aorta will be coming off somewhere towards us, right? But from the common chamber, somewhere around here. Right? But this is crazy, right? I gave you a little bit more information. This is what it looks like in the embryology itself, the picture. It just tells you the interatrial, that is the septum that is supposed to be between the atria, and the one that is supposed to be between the ventricles. They fail to meet and fuse. So you have defects of both mitral and tricuspid. This is a very bad thing. Now let's talk about Eisenmenger syndrome. Anytime you have a left to right shunt, patent ductus arteriosus, atrial septal defect, ventricular septal defect, only when you have a left to right shunt, the one that does not cause cyanosis, the ones that your patients will be okay for a while. Well, they may feel okay, but they're not really okay. Because what happens is with increased flow to the lungs through the pulmonary artery, you begin to affect the architecture of the pulmonary artery. You're putting so much volume into the pulmonary artery, it is causing structural changes in the pulmonary artery. The pulmonary artery begins to get more muscles and begins to constrict to protect itself from exploding. So it gets, look how the lumen is being compromised by the increased thickness of the tunica. So that increased blood flow creates what is called a shear stress and circumferential stretch, vascular damage and remodeling. Bottom line, increased pulmonary vascular resistance. With increased pulmonary vascular resistance, you get increased right ventricular pressure. With increased right ventricular pressure, you reverse that shunt. The patient becomes hypoxic and they become cyanotic. So Eisenmenger syndrome is important because it can convert an acyanotic congenital heart disease to a cyanotic congenital heart disease. It reverses the shunt, turns a left to right shunt into a right to left shunt that makes the baby cyanotic. Remember the three pathophysiologies of cyanosis? Right to left shunt, right? Common mixing or parallel circulation. So when you develop pulmonary hypertension as a result of a left to right shunt and the shunt reverses, you convert an acyanotic heart disease into a cyanotic heart disease. Everybody good?
Is the increase
Yes.
pulmonary blood flow because of the compromisation of the lumen?
No, you increase the left to right shunt, first increases the volume to the right ventricle. And the right ventricle now pushes all that volume into the pulmonary artery. Now the pulmonary artery is getting this excess volume. And in order to be able to accommodate it and not get ruptured, it changes its own structure. By changing its own structure, it gathers more muscles and more tunica tissues and compromises its own lumen. When it compromises its own lumen, its own resistance increases. Then it begins to stress the right ventricle. And then the right ventricle becomes hypertrophied. Then the left atrium tries to now, because once the vesicle becomes hypertrophied, it becomes more difficult to distend. It's like a thick rubber, more difficult to distend. The right atrium now has difficulty pushing blood into it. Then the right atrial pressure now also increases. Then the shunt gets reversed. Yeah.
But if it didn't compensate, then you can have a pulmonary aneurysm.
Why are you thinking pulmonary aneurysm?
Because you know you were talking about. I'm just
Pulmonary aneurysm will need to happen when the vascular wall is thin and fragile. That's when it balance. When you stress it with pressure, it gets thicker. So it's less likely. And in fact, aneurysms don't happen too much in the pulmonary vascular beds. I've never heard that before in the pulmonary vascular bed. Any day we diagnose that, they will just go to new course. All right. Everybody good? Can I move on? All right. Ah. That's it.
No.
No, more.
Oh, wait, we have more lectures.
We have more.
All right. Yeah. Which of the following heart disease is not known to be associated with central cyanosis?
That's it.
I thought I said me already.
Who? You didn't say anything. You said a name.
No, I said, okay. All right. So, what did you guys say it is?
That's it.
B. Good. All right. Tia, which of the following heart diseases is known to be associated with central cyanosis? Huh? Read the answer. Don't tell me the alphabet. Tetralogy of Fallot. Good. All right.
Oh, okay. All right. Cool.
Now, I'm going to go quickly right through this because this is a summary of everything I've been telling you. And this is really a physical diagnosis slide. What I'm trying to do here is to teach you, when you listen to a heart and you hear murmur, the first decision you have to make is, this murmur, is it coming from the right side of the heart or is it coming from the left side of the heart? That's the first decision. Then you try to use the location, aortic, pulmonic, tricuspid, mitral, to see where is loudest. And then you have to decide, okay, if you locate it to the right side or the left side, you have to ask yourself, is it coming from an inflow valve or is it coming from an outflow valve? One of the beautiful things of being a good clinician is that you don't do tests to figure out what is wrong with your patient. No, you do tests to confirm what you're thinking. Okay. Do not be technicians, be clinicians. Okay? That is why respiration is important. Because if the murmur is louder with inspiration, that means it's a right-sided murmur. Okay? If the murmur is louder in expiration, then it's a left-sided murmur. And you should understand that. Because with inspiration, you increase flow to the right side and you decrease flow to the left side. Because once you inspire, you increase the lungs distance, you increase the pulmonary venous capacitance. More blood pools in the lungs in inspiration. And since more blood stays in the lungs in inspiration, that means less blood is returning to the left ventricle. So flow through the left is less. So the murmur, turbulence will be less. So if the murmur is louder in inspiration, that is a right-sided murmur. If the murmur is louder with expiration, because remember, in expiration, the lungs collapse. And the lungs are like sponge. So when you squeeze it, it empties itself. So in expiration, the lungs collapse. They increase venous return to the left. And because of the positive pressure in the chest that you create in expiration, you reduce venous return to the right. So you create the opposite. You got it? So if the murmur is louder in inspiration, probably a right-sided murmur. If it's louder in expiration, it's probably a left-sided murmur. Now, if it is a right-sided murmur, then that means it could come only from tricuspid or pulmonic. The next question you ask yourself is it a systolic murmur or is it a diastolic murmur? Does it rhyme with the pulse or does it alternate with the pulse? If it rhymes with the pulse, then it's a systolic murmur. Then you ask yourself, what can give me a systolic murmur between tricuspid and pulmonary? Only tricuspid regurgitation and pulmonary stenosis can give me systolic murmur. Right? Are you with me?
Yeah.
Good. And then, if it is tricuspid regurgitation, it will give me a systolic murmur and it will soften my S1. Right? If it is pulmonary stenosis, it will give me a systolic murmur, but it will soften my S2. Right? Right? That was why I told you last week that if a valvular disorder gives a systolic murmur, it will soften whatever sound of the heart it makes. If a valvular disorder gives you a diastolic murmur, the heart sound that valve makes will be loud. So I kind of get you thinking about this last week. Are you all with me? Excellent. So the same thing. Unfortunately, on the right side, you don't have the luxury of the pulse, because your pulse does not reflect anything on the right. It reflects everything on the left. So on the left, if you're able to say, well, this murmur is coming from the left side of the heart, well, then ask yourself, is it a diastolic murmur or a systolic murmur? You say it's a diastolic murmur. Then if it's a diastolic murmur, it can only be mitral stenosis or aortic regurgitation. How do I tell them apart? Beautiful thing is that in aortic regurgitation, there is this wide pulse pressure and the pulse is bounding. The pulse is the volume shift across the aortic valve in aortic regurgitation is so intense that when you look at old people with aortic regurgitation, their head bobs with their pulse. And their pulse is huge when you raise it up. We call it water hammer pulse. Okay, so aortic problems will reflect in the pulse. Mitral will not. In addition, mitral stenosis will give you a loud S1, right? Whereas aortic regurgitation will give you a loud S2. Are you with me? You better make sure you're with me. If you're not with me, speak up now, because in your exam, I will paint some beautiful clinical pictures for you. And nothing breaks my heart more than you not being able to pick on the clues. I feel this question with a lot of clues, and you can't recognize it. That really bothers me. Because I'm not training you to be professors, I'm training you to be clinicians. And I need you to be, I want you to be the one telling the echo tech what to look for, because you already know what you're thinking this patient has. Not wait for him to tell you what the patient has. You are the clinician. So this is so important. I need you to be able to tell diastolic murmur, systolic murmur. What does it mean? Can the pulse help me here or not? And what am I looking for in the pulse? Okay? You time your pulse, I already said that. First heart sound, loud and soft, yada yada yada. People like to talk about grading murmur. 2/6 murmurs, 5/5 murmur, crap. We don't hear like that. Okay? So we make it up. Barely audible, audible, but soft. Easily audible. What the heck is that? But that is what they say. I've already told you what I want you to know. If you can put your stethoscope on the chest and you can hear it, but when you lift one side of it with only one side of it touching the patient's chest and you don't hear it, that is a soft murmur. If you could hear it on one side, that is a grade 3 murmur for sure. If you could hear it with your stethoscope completely off, that's a grade 6 murmur. See, everything in between is crap. Clinically, you don't see, that's not the way you see it. You have to be able to identify it easily. Okay? So if you put your stethoscope right on the patient's chest and you hear it, give it, that's a grade 3 murmur. Easily audible, flat on the chest. If you hear it with only half of the stethoscope, that means it's even softer than that. That is grade 1, 2. Right? If you hear it with the stethoscope completely up the chest, that's grade 6. Okay. So you see 2 and 4, they are crazy. 1, yes. 6, yes. 3 is standard. Okay? So if you hear any murmur, just call it 3. If you can hear it with the stethoscope completely off, call it 6. If you can hear it with only one half, call it 2. People ask you, how are you able to say it's 2 versus 1? And just tell them, because I don't think 2 really, I think it's in all of my minds. Reality is I know when it's soft, I know when it's really loud, and I know when I heard it. And tell them what I told you. They will look at you strange, but they won't be able to argue with you. Because it just makes it, that's the way it works in practice. Okay? Again, I give you more examples about dynamic auscultation. And again, I give you reasons why these are the way they are. Respiration increases the intensity of right-sided murmur, decreases the intensity of the left-sided murmur, yada, yada, yada. This is everything I've been telling you, I'm just explaining it. I'm explaining it more for you guys, okay? Now, there are some conditions that we still need more intense or additional maneuvers to differentiate. And I want you to be familiar with those. Sometimes respiration is not good enough, okay, because let's face it, the heart is beating at 70, 72 beats per minute. Your patient is breathing 15 times a minute. It's difficult to kind of like tell what is happening to the sound in inspiration versus expiration. Even when you tell the patient, take a deep, slow breath, you still have to struggle. So we have resorted to maneuvers to increase the preload and increase afterload, right? So basically maneuvers that will help us reduce or increase venous return to either side of the chambers we're interested in, right? To increase venous return, what we normally do is to raise the leg, right? Or we do Miller maneuver. I already talked about Miller maneuver last week, right? Good. So you see what it does? When you increase venous return, you increase the intensity of the right-sided member, because that is equivalent to inspiration, right? And then, if you want to decrease preload, you tell the patient to stand up or to do Valsalva. See? So that will decrease the preload, like create a positive pressure in your chest. That is what happens in expiration, right? You create a positive pressure, you decrease venous return to the right, right? So you can use Valsalva to do that. And it tells you what it will do to the right-sided and left-sided member. But notice here that mitral valve prolapse and hypertrophic cardiomyopathy, they do the opposite most of the time. That has a lot to do with the pathology that we're dealing with here. And I think there is room for me to talk about it down the road, okay? I will explain it to you. After load, you tell the patient to give you a hand grip, like that. That's how you increase after load, okay? Or you tell them to squat, right? And it does that, it decreases the intensities of the, it tells you what it does to the murmurs. And amyl nitrate inhalation, nobody does it in practice, but somebody might ask you. It is usually given to decrease the intensity of regurgitant murmur, right? And I give you a little bit more explanations here. This is not where you're supposed to learn this. It's supposed to be physical diagnosis, but I'm just getting your feet wet. Basically, know that you can increase preload and afterload, and how can you do it? Because as we go forward, I'll tell you, especially for mitral valve prolapse and hypertrophic cardiomyopathies, I will explain to you why this is the case. Okay? When the heart is failing, the veins get congested. When the veins get congested, we call it jugular venous distension. But if you take a closer look, you will notice that the vein is not just distended, it's pulsating. And those pulsations, they have specific waves. And sometimes those waves, their configuration are telling in clinical evaluation. If you know how to interpret them, you know how they originate. So jugular venous pulsation is what I'm going to talk about now. So the first wave of jugular venous pulsation is the A wave. So you can imagine when the right atrium contracts, right, the pressure increases in the right atrium. There is no valve between the right atrium and the superior vena cava. So that pressure gets transmitted into the superior vena cava and is reflected in the neck as a wave. So that is how you get the A wave. When the ventricles contract in systole, this is your normal ventricle. When it contracts, it shrinks and contracts down, right? So when the ventricles, the right ventricle specifically, when it's in systole, it contracts on itself, it pulls the atrioventricular ring downwards, right? And because it does, it creates more volume above it. And that is reflected in the neck as that C wave. No. The atrial contraction, I want to make sure you understand this, please forgive me. The atrial contraction is what gives you the upswing of the A. What I just told you, the ventricular systole and the descent of the atrioventricular ring is what is responsible for the downwards limb of that A wave. Okay? You got that? Now, in the middle of systole, when the pressure in the right ventricle is highest, the tricuspid valve will bulge. Okay? Because remember, the tricuspid valve is just cusp and cords that hold it. When everything is contracted down, the ring itself descends, but the valve cups are pushed up because they are fibrous tissue. They're not muscles, right? So they balloon up. That ballooning of the tricuspid valve is what creates that the C elevation in the wing. Okay? And then the valve opens, the contraction continues, and the descent continues, and that is what you get the X wave. And then when the ventricles, the tricuspid valve opens and blood rushes to the ventricle, it creates a back pressure that is responsible for the V wave, and then the filling of the ventricle in diastole, it gives you the V wave. Why am I bothering you with this? Because if you have tricuspid stenosis and the atria is contracting against an obstruction, this wave becomes bigger. Not just bigger, it becomes gigantic. So big that we call it the cannon wave. Okay, that's why I'm mentioning this. Okay, it becomes the cannon wave. It's a giant air wave. And when you have tricuspid regurgitation, this V wave becomes huge. So you see when we talk about tricuspid regurgitation, we say they have giant V wave. Okay? All right, this is tricuspid valve stenosis. Now I'm going to move like lightning because I have 50. How many more slides do you guys have in your stuff? 20? 22? 22 slides? What the heck happened to time? Wow. Why am I behind? Okay, I'm going to really move fast. But it's easy because everything we're going to talk about now, we're going to talk about some. So, tricuspid valve stenosis in the US, usually due to prior valve repair, carcinoid syndrome, congenital malformations, malignant metastasis, or lupus. Outside of US, rheumatic fever. So if I paint a picture of tricuspid valve stenosis for you, and I tell you this is a recent immigrant from Guatemala, you know I'm not asking you to look for prior valve repair. I'm telling you this is somebody on vacation from Burundi. You know I'm not asking you for prior valve repair. You're more likely rheumatic fever. Okay? Then clinical features tend to be more common in females. They have a right heart failure with systemic venous congestion. They have a diastolic murmur with a presystolic accentuation. You know what that is? Because it's a tricuspid stenosis, right? Normal right ventricular field is passive. It's only in the last third that the atrium finishes it. So when the blood is flowing passively through that stenosed valve, it gives you a particular murmur. When the atrium is now forcing blood through it in its own systole, that murmur becomes louder. So it becomes whoo, So that the last part has higher intensity. Okay, so that higher intensity that you get with the last part is what we call this presystolic accentuation. Okay, and you see what I told you? The jugular venous distension will give you giant airwaves, and you see a slow white descent. You have a positive cosmal sign, right? In other words, what is the positive cosmal sign? When you look at the vein, and you tell the patient to take a deep breath, the vein becomes more engorged. Is that normal? That's not normal. Because during inspiration, you're creating negative pressure in the chest. That should suck in blood. So the veins should collapse with inspiration. That is what is normal. But because of stenosis, you increase the venous return but the orifice is narrow. So that creates extra volume, narrow orifice, back pressure in the neck. So the vein in the neck is distended with inspiration instead of collapsing. And that distension is what we call Kussmaul sign. And of course, you get hepatic liver, enlarged liver with presystolic pulsation as well. When you do EKG, you see right atrial enlargement, of course, because the right side is dealing with this. You do echo, you find, and this is important, pay attention. Why do we always do echo and EKG? Why can't we do one? Because EKG will tell you a little bit about the chamber structures. Echocardiogram will tell you about the chamber structure as well, but with one important difference. With echo, you can actually measure the pressure gradient. With EKG, you can't. Okay. So if I have tricuspid stenosis, on EKG, I can see right atrial enlargement, yeah. But with echo, I can tell how tight is it, because I can measure the pressure gradient, the pressure in the right atria and in the left ventricle. What is the pressure across that orifice? So how tight is it? I need echo to do that. You can't do that with EKG. Okay? And of course, the liver gets enlarged, and because of that, its enzymes get elevated. Rarely would you need cardiac catheterization. How do you treat it? Diuretics, diuretics, diuretics. Surgery for refractory cases. When must you do surgery? When your patient is refractory, is not responding to the diuretics anymore. One big problem with fixing tricuspid valve stenosis is once you send your patient for surgery, you can expect a good number of them to come back with tricuspid regurgitation. The surgeons will convert the stenosis to regurgitation because they don't fix it right. Okay. Okay, how did they fix it? Well, they replace it. Okay, because the repair is terrible. Because what they do with the repair is they put a balloon, right? They put a balloon through the cusp and then inflate the balloon. And they're usually not able to gauge how much they should inflate the balloon to stretch it open. So many times they will overstretch it. And then they will convert a stenosis to a regurgitation. Which one would you rather have? Stenosis, yeah, because regurgitation creates volume problem. And lungs might be at risk. At least stenosis, your lungs are protected, right? So that's why many people don't like repair. They prefer replacement, okay? And you can replace it with a bioprosthetic valve or a mechanical valve. What is the difference between them? Well, bioprosthetic, they are less thrombotic. They last for about 10 to 15 years. Mechanical, they are more thrombotic, but you need lifetime anticoagulation. So these are difficult decisions to make. Okay, if you're dealing with an old person, this is not a one-man decision. This is a decision you make with the cardiologist, the internist, yourself, the patients. Because lifetime anticoagulation versus we're going to need to fix this again in another 15 years. So if you're dealing with a 26-year-old, you're likely to, you're going to need to go there 3 times. The risk for over their lifetime, 3 to 4 times. You have to weigh that risk to, okay, let's do mechanical. And for the rest of their life from age 26, they're going to be an anticoagulant. See how we balance risk in medicine? Yeah. Tricuspid regurgitation, less common, usually due to infective endocarditis, rheumatic fever, carcinoid syndrome, myxomatosis degeneration, congenital malformation. Let me just tell you, I don't ask you what causes what valve problem. Because at the end of the day, it does not matter. Whether you got it from infective endocarditis, rheumatic fever, it doesn't matter. We're all going to send you to surgery. You will present the same way. So learning the specific cause of it is not important clinically. It does not matter. It doesn't affect the treatment. Okay, so I won't ask you. But that does not mean others won't. Okay, so for your parents, I do. See if you can memorize them. That's the only way. Because there's no other way. But for me, if I was to set your past questions, I would not ask you any of this type of crazy stuff. What does it matter? I don't. You think I remember that? Because I repeat it so much, I might remember some of it. But it's not important. So don't expect, I won't ask you. Okay?
So, who sets the questions, advanced questions? Who sets them?
Oh, your board, your people said that. We have nothing to do with that. You know, it's interesting. It's like the PA and the CPA exam. The CPAs that are in practice, they make it so hard, you know, for the people to come. And I'm looking at some of your past questions like, why? Why do you ask these kind of questions? Even some fellows can answer these questions that thoroughly. It does not make sense. I believe your lectures should be on guidelines, understanding why they are the way they are, and how do you practice as clinicians. Current treatment, diagnosis, recognize danger, help people. You're not going to be professors. Why do I want to teach you controversial stuff? If we are not settled on it, why do you need it? I don't even need it. I go to conferences to figure out what they're arguing about. I just want to listen. But what I want you to remember is secondary is more common. How do you get secondary tricuspid valve regurgitation? Anytime you dilate the right ventricle, you're going to get tricuspid regurgitation. So most patients with dilated cardiomyopathy, they have tricuspid regurgitation because the ventricles dilate and the cusp spread from themselves and becomes regurgitated. Got that? And again, the same way, right heart failure with systemic venous congestion, systolic murmur, right ventricular S3 because of the volume, jugular venous pressure, and I told you the giant V wave, enlarged tender liver with systolic pulsation. Did you remember that? In tricuspid stenosis, you get pre-systolic hepatic pulsation because that pulsation is caused by atrial contraction against an obstruction, and the back pressure is transmitted to the liver just before systole starts. So it's a pre-systolic because it's under the influence of the atrial contraction that happens late in the diastole to complete the ventricular filling. Tricuspid regurgitation happens when the ventricles are in systole. So the back pressure is to the liver in systole. So in tricuspid regurgitation, the hepatic pulsation is systolic, whereas in tricuspid stenosis is pre-systolic. You got that? Right? Does it make sense?
Not really.
Okay. Let's think it through. Aorta and atria contract to complete right ventricular filling. Only in the last third of diastole. The ventricles, the tricuspid valve opens, the ventricles are filling, they are 2/3 filled, then the atria contract to finish it up, so the ventricle can go into systole. So when there is tricuspid stenosis, the passive filling takes place, no problem. When the atria now tries to squeeze blood through that narrow orifice, it creates back pressure. Since that atrial contraction is happening in atrial systole but ventricular diastole, right? And atrial systole is not a big muscle, it's not a big chamber. So that contraction of the atria, the right atrium, to fill the right ventricle, creates back pressure that creates the giant A wave, right? And create pre-systolic, the hepatic pulsation just before systole. Now, when the ventricles now fill and they are now in systole, and the tricuspid valve is supposed to close, it now opens back into the right atrium. Pressure gets transmitted from the right ventricle into the right atrium and creates a systolic pulsation in the liver. So in tricuspid regurgitation, you get a systolic pulsation of the liver, whereas in stenosis, you get a pre-systolic pulsation of the liver. Got it?
Sorry, can you go back to the why secondary
very the most common?
Because the right ventricle has a fixed size, right? And the cusp, they are fixed size. When it's normal size and everything is working, they are closed and they close when they're supposed to close, they open when they're supposed to open. Now you get CHF, congestive heart failure, and your ventricles dilate. Well, when your ventricles dilate, your cusp don't elongate, right? So they now start from here, and they stop here. They start from here, and stop right here. So the valve is open all together all the time. So it's the cusp separation. The cusp separation with ventricular dilatation that gives you the tricuspid regurgitation you get when the ventricles are dilated. Okay? Are we good?
Yes.
Excellent. And then you do all this other stuff, echocardiogram for the same reason, liver enzymes for the same reason, cardiac fractures, treatment, diuretics. You fix it if you can. You can't fix it, you replace it. Bottom line. Pulmonary valve stenosis is usually congenital but can be acquired, and usually is the carcinoid syndrome. It could be at the valve level or it could be below the valve, right? Pulmonary stenosis can be asymptomatic for years. And when it becomes symptomatic, it will give you right heart failure with systemic venous congestion. It will give you a soft S1, right? I'm sorry, soft S2. When you examine the patient, you get a right ventricular heave. You know what a right ventricular heave is, right? Usually, when you put your palm on just along the sternum, that palm is sitting over the right ventricle. When the right ventricle is hypertrophied, you will lift your hand like that. That's what we call a right ventricular heave. Sometimes it will be described in an exam as a left parasternal heave. Heave, as in Heave, heave, uplift, like upheaval. You got it? So it is described as a left parasternal heave. If I'm going to set the exam, I won't call it a right ventricular heave. I will call it a left parasternal heave. Because I need you to know that, well, if it is a left parasternal heave, is sitting, it's talking about the right ventricle, because the right ventricle is what is on the right of the stomach. Okay? So you have a right ventricular heave. You have a flow-mediated but non-fixed splitting of the S2. We'll talk about that. Then you have right ventricular S4 because of the pressure overload. Remember I told you when the chamber is pressure overloaded, you get S4. When it's volume overloaded, you get S. Okay, good. Jugular venous, giant airway. Again, right ventricular hypertrophy on EKG, echocardiogram for pressure gradient, liver congestion, make liver enzymes go up. You may or may not need cardiac catheterization. Watchful waiting because they are asymptomatic for so long. When must you do surgeries? When all these things are there. Patient becomes symptomatic, peak gradient exceeds 60, mean gradient exceeds 40. You will fix it under these conditions. Do you need to know that? Maybe not. But I will ask you. I don't expect Pounds when I ask you this. This is cardiology people that will ask you. But because I'm telling you, I have the right to ask you. Intervention, balloon valvuloplasty is preferred. And if that does not work, you do replacement. Okay. Now, pulmonary valve regurgitation. Secondary, usually due to pulmonary hypertension, remember? Pressure from the lung is what will force it open on the other end. Okay, less often it is idiopathic after dilatation, and on rare occasion it follows infective endocarditis, carcinoid syndrome, and surgery for tetralogy of Fallot. So the kind of patient that will come with pulmonary, if I want to give you a story of pulmonary valve regurgitation, it will be a 26-year-old with a history of tetralogy of Fallot stethoscope surgery, right? Stethoscope means just had, currently just had surgery, and I will now paint a picture of pulmonary valve regurgitation. And I will now tell you what is the most likely etiology for the pulmonary valve regurgitation. And I'll tell you, is it idiopathic, or is it carcinoid, or is it endocarditis, or is it a post-op complication of TOF surgery? So if I give you all that, you should be able to tell me what that is. Your patient will be asymptomatic for a long time. When they become symptomatic, it will be a right heart failure. You will see that you will hear diastolic murmur, and that murmur is a very interesting murmur, because it's a diastolic murmur, all right, but it is known as Graham-Steele murmur. We don't use this anymore these days. People don't use people's names anymore. Just know that it's a diastolic murmur, right? And then you have a right ventricular heave. And again, you have a volume-mediated wide but non-fixed splitting of S2. And because of the volume overload, you can get an S3. Right? So see, it's okay, I'm very comfortable with what I'm doing, because all of these things, there is nothing under these clinical features that we have not talked about. Right? So this is really reviewing what we've already talked about. Okay, am I going too fast? I am. Okay, do you guys have 30 minutes? You have 30 minutes?
Yeah.
Okay, all right, I'll slow down. All right. Then EKG will show right ventricular hypertrophy because you're volume overloading the right ventricle, right? Echocardiogram again will show you the regurgitant jet. You can see the pressure. Liver enzymes will be elevated because of hepatic congestion. How do you treat it? Pay attention to this one. Pulmonary valve regurgitation. Surgery is not your first option. Congestive therapy is not. Because most of the time, the reason blood is flowing back through the pulmonary valve most of the time is because of pulmonary hypertension. So you will treat and control pulmonary hypertension. Okay? When would you do surgery? When you have right ventricular dysfunction. And what surgery will you do? You will replace it. Okay? I want you to pay attention that when the valve is stenosed, balloon valvuloplasty is an option. But when it is regurgitated, you have to replace it. Okay? Yeah. Aortic valve stenosis, big deal. Pay attention to this one. It could be congenital when the aortic valve has 2 cusps instead of 3. It is inherited. Bicuspid valve is an anomaly. A normal aortic valve has 3 cusps, so it's a tricuspid valve. But we don't call it tricuspid valve because we call tricuspid valve, right? But the aortic valve also has 3 cusps. When people are born with aortic valve that has only 2 cusps, we call that aorta a bicuspid aorta. Now, this bicuspid valve is usually associated with aneurysm of the ascending aorta. So this you have to pay attention to. If you see somebody with aortic stenosis, you must screen them for aneurysm of the ascending aorta. That is the only valvular condition you should worry about, because the problem where the murmur or the valvular disorder could be a sign of something more catastrophic waiting to happen. Okay. So you must remember that. Bicuspid valve is usually associated with aortic coarctation and progressive dilatation of the ascending aorta. Okay?
And that's because the pressure.
It has nothing to do with the pressure, it's the pathology. Yeah, it's the pathology. Yeah. And it becomes bicuspid valve, they don't become sick immediately. They are sick in their 5th decade. That is in their 40s. Okay, that's when they become symptomatic. All right. And then it could be idiopathic just because of age, or it could be due to atherosclerotic diseases. So hypertensive, diabetic, people uncontrolled, hypercholesterolemia, Over time, they can develop aortic stenosis, purely degenerative atherosclerotic disease, causing aortic valve stenosis. Okay? In developing countries, Jamaica, or rural give me a neighborhood in Russia.
What?
I want a neighborhood in Russia that is poor.
Siberia?
Iberia, thank you. And which other one? Another one in Europe. Poor neighborhood.
Georgia.
Huh?
Georgia.
Croatia, yes.
Georgia.
Georgia, in Russia. Oh, they are poor here? Oh, I thought they Anyway, when you are talking about developing countries, aortic stenosis, remember rheumatic fever, okay? How does it present? Aortic stenosis presents with the triad: syncope, angina, and left heart failure. Angina is first. If it is a very tight obstruction, they get syncope. When do they get syncope? When they exercise. He was on his jogging trail and he passed out. That is because the amount of blood he needs to keep moving cannot go through his aorta and still maintain cerebral perfusion. So he will pass out. Okay? So syncope, angina, left heart failure. When you look at their pulse is low volume. In your class they call it amplitude. Amplitude is when you measure it with the machine. When you feel it with your pulse, it's a volume you feel. Okay? So, low peripheral pulse volume with a delayed upstroke and a narrow pulse pressure. So when you look at the difference between the diastolic and systolic blood pressure, usually less than 30. Normally, there should be at least a difference of 30 between systolic and diastolic blood pressure. When you have aortic stenosis, that difference is less. So the pulse pressure is narrow. Okay? Are you with me? Good. You have a soft single S2 with sometimes in severe cases with reverse splitting. You have a systolic murmur. You have a left ventricular S4. And then you have something strange. Because the left ventricle is a high pressure chamber, everything in that left ventricle is happening under very intense pressure. And now when the aortic valve is now narrow again, that even increased the turbulence through that valve. And because of that, you destroy the von Willebrand factors in that turbulence. Okay? Von Willebrand factor is one of those clotting cascades, right? So you destroy this one, and when you destroy that, you predispose the patient to bleeding. So aortic valve stenosis can present with GI bleeding. Okay? Because of the turbulent damage to the von Willebrand factor. And I give you a little note under here. It said the degradation of the von Willebrand factor multimer by the elevated shear stress of the turbulent flow across the stenotic valve. So von Willebrand factor exists as a multimer. In order for it to work effectively, it has multiple polymers of its molecules joined together like a sheet. When they go through the stenosed aortic valve under the high pressure, those polymers that are allied together get fragmented. And because they get fragmented, von Willebrand factor is not able to do what it would normally do, which is to maintain vascular integrity and blood leakage. So, aortic valve stenosis patients are prone to bleeding, especially in the GI tract. Okay? Very important information. Again, diagnosis, EKG, echo. Because they always present with chest pain, we always do stress test. Okay, because you don't know when it is coronary artery disease, You don't know if it is aortic stenosis that is causing the chest pain or the smoking, hypertension, and diabetes. Right? You hear the murmur, yeah, but the murmur doesn't mean that the murmur is responsible for the chest pain. If the patient has enough risk factors for coronary artery disease, you need to do stress test. Right? As a matter of fact, nobody fixes aortic stenosis without doing cardiac catheterization. Cardiologists have learned. Because they've gone in and thinking that patient has chest pain because of aortic stenosis, and they will spend their time fixing the aortic valve, only to come out and find that there is a major lesion in LAB. Like, oh man, now we have to go back. Because what we fixed was not the cause of the problem. So generally speaking, they don't fix aortic valve stenosis without doing cardiac catheterization. Okay? Now, if you diagnose somebody with aortic stenosis, you want to avoid the use of nitrates and vasodilators. Why do you have to do that, Dave? Yes, because vasodilators will increase. I mean, think about it. If the aortic valve is narrow and you are dilating the vessels after the stenosis, you're increasing the pressure gradient. Right? I mean, think about it. Under normal circumstances, in the ventricles 140, in the aorta 140. Right? So there is not much. This is under normal circumstances. Right? If there is stenosis, ventricles 140, but because of stenosis, probably about 100 here. Right? If you now give, this is the heart, this is the body. If you now give the patient vasodilator, you drop the peripheral resistance. The gradient will now become 140, 60. So what happens? What will happen to the patient when they exercise is what you're going to cause to happen with your vasodilator. That is why we don't give vasodilators to patients with aortic stenosis. So the way I will ask you this question is to give you somebody that comes in with it looks like essential hypertension, but I'll paint the picture of aortic stenosis, and I'll tell you which of the following medications will be most appropriate for treatment of this patient. And I'll put a bunch of vasodilators there and nitrates, and give you one beta blocker. So you know that you should be careful with nitrates and vasodilators in people with aortic stenosis. Okay? When would you, sometimes they can be asymptomatic, but it does not matter whether they're asymptomatic or not. Whenever the valve area is less than 1 centimeter square, or the left ejection fraction is less than 50, or the mean gradient is more than 55, or the peak jet velocity is more than 5, surgery is indicated. Nobody but me will ask you this. And I can tell you right now, when I ask it, the answer is always all of the above. Okay. My goal is not to make your life more miserable than it is. Okay. All right. Again, because it's stenosis, valvuloplasty is an option. Right? But the problem with it is even when it works, restenosis is very quick, especially if you do it in the elderly. So in children, it works better. When that fails, you have to replace. And if you replace with mechanical valve, that means they have to be on anticoagulant for life. Okay? Now, aortic valve regurgitation. Am I going at the right pace for you now?
Yes.
Okay, I know it's a lot of content, but think about it. It's a lot of repetition. It's not new information. It's going through what we talk about. I need you to change your mental outlook. You're all looking like I'm drowning you or waterboarding all of you. No, it's because you're looking at the volume. Pay attention. This is repetition. Very few things I'm saying here now that I've not said all morning. Very few. Example, the only thing we didn't talk about is these causes of it. For every single thing I've talked about, diagnosis has been EKG, echo, and cardiac cath for every single one of them. For every single thing I've talked about, it's been about valvuloplasty and valvuloplasty. So the only new information really is the etiology. And I already told you it's not going to be an exam. So you should pay attention and be more positive and stop looking like I'm baptizing in lemon juice. And learn only the what is important and stuff. Come on. It's not a lot of information. I know what I'm doing.
I never heard that one.
Good. Y'all looking like, when is it gonna? Not that bad. So, aortic valve regurgitation usually is due to aortic root disease. And you see that? Aortic root disease, bicuspid aorta, again. And then there is these crazy guys, you've seen them, these guys with super soft connective tissue. They can put his leg across his neck. They're so flexible. They call it Marfan's and Ehlers-Danlos syndrome. You know them. They are at risk for aortic root diseases that will lead to aortic regurgitation. See, long-standing, uncontrolled hypertension. Remember, what is the commonest cause of pulmonary hypertension? What is the commonest cause of pulmonary regurgitation? Hypertension. Good. What is the commonest cause of aortic regurgitation? Systemic hypertension, uncontrolled. Okay? And then you have rheumatic disorders. Syphilis and Takayasu arteritis. We'll talk about Takayasu. Syphilis you all know already. Infective endocarditis, rheumatic fever. How does it present? Again, all aortic valve diseases, angina, syncope, and left heart failure. But what is unique about this is their high pulse volume. So aortic regurgitation patients have pressures like 180/90. You know, the pulse pressure is usually excess of 90. They have a diastolic murmur with a loud S2, right? They have an S3 because of the volume overload, right? Do you know what this can do to a person? A pulse pressure of 90. So you're getting a pressure like 140 over 50. Right? You're getting pressures like 160 over 60. The pulse pressure, the difference between the systolic and diastolic pressure is usually very high. So that leads to a lot of signs, which we'll talk about later. Diagnosis, EKG, echo, cardiac cath. How do you treat diuretics? You see now, you give nitrates. You know why you want to give nitrates? Because if you vasodilate, less blood will go back. Because blood is liquid. It follows the path of least resistance. So aortic regurgitation will be helped by vasodilators. But aortic stenosis will be hurt by vasodilation. Make that difference clear in your mind. So the way we do it, we give them A's and R's. When do you intervene? Whenever these parameters are met in symptomatic patient. Even if the patient is asymptomatic and they meet these parameters, you must intervene. What do? You replace the valve. If you use mechanical valve, you have to put them on life-term anticoagulation. Remember, I keep writing no NOACs. NOACs are the new oral anticoagulation. You don't use those for valvular disorders. You don't use it in atrial, in valvular disorders. They are not recommended for that. You have to go to the old regular warfarin. Okay? Okay, good. Now, look at all the signs you can get as a result of aortic valve regurgitation. You get this murmur called Austin Flint. You know what Austin Flint murmur is? So you see, when you have aortic valve regurgitation, at the end of systole, when the ventricles are relaxing, aortic valve is leaking blood into the ventricle, right? At the same time, normal flow is flowing from, normal blood flow is occurring from the left atrium through the mitral valve into the same left ventricle. So two jets of blood stream is colliding inside the left ventricle. That creates a separate turbulence themselves. That one is called the Austin Flint. Just remember conflict. Okay? The Austin Flint murmur. Right? Then you have the cold Cecile murmur. It's a diastolic murmur as a result of ventricular failure from both the left and regurgitants. Right? Sorry, what I just described about the cold Cecile. Austin Flint is diastolic murmur of obstruction due to mitral valve inflow from mitral valve preclosure by the regurgitant jet. Yeah. What I'm trying to say here is aortic valve jet is recurring and pushing the mitral valve closer to close. Instead of the mitral valve opening, the jet from the aorta is pushing it up to close almost early, creating a relative obstruction in the mitral valve. Okay? The collapsing of the jets is the cold Cecile murmur. Did you understand the Austin Flint?
No.
Okay. Left ventricle, aorta, mitral valve. When the blood is, when left ventricle is relaxed, and blood is supposed to go into the left ventricle through the mitral valve. Blood is leaking through the aorta at the same time. So because of this jet coming down here, the cusp cannot go down like it should. So it hangs higher than it should, creating a relative obstruction that creates a diastolic murmur. That is the Austin Flint murmur. Now, when the jet from normal filling and the regurgitant flow collide in the left ventricular chamber, that gives you the cold Cecile murmur, right? They have all these crazy things that happen: Trowbridge sign, the pistol shot, Drozé sign, main sign, Hill sign. Blood pressure is higher in the systolic pressure is higher in the leg than in the arms by more than 10 to 20, sometimes by more than 60. I was surprised the last time you guys, nobody took pipe pressure. I think it's important you learn to take pipe pressure, because Hill sign is when you have excessive difference between the blood pressures in the arm and in the leg. Under normal circumstances, the farther from the heart you measure blood pressure, the higher it is. So blood pressure is higher in the fingers than in the wrist than in the brachial. Right? It's higher. The highest pressure is here. Right? The farther from the heart, the higher the pressure. So it's higher in the legs than the arm. Right? But in aortic valve regurgitation, the difference is enormous, more than 60. And then you have all these crazy signs. Look, I might put some things here. You just need to know these signs. You know, Demoset sign, head bobbing, Corrigan collapsing pulse, or water hammer pulse. Queen case, if you look at the nail capillary bed, you can actually see with the right instrument, you can see the nails blanching with every pulse because of the massive volume shifts. Okay, Becker's, Rosenberg, Gehard, Mueller. I think you find this interesting. Look at Mueller. You get somebody, open your mouth, say ah, and the uvula is doing this. That is, you'll see that in aortic regurgitation. All right. Whew. Now I'm beginning to feel like I'm forcing you guys to drink through a fire hydrant. Mitral valve stenosis usually follows rheumatic fever, female preponderance. Again, pulmonary congestion exacerbated by exertion and pregnancy. They have chronic cough. 80% of the time, atrial fibrillation. Late, they get pulmonary hemorrhage. They have a loud S1. They have a diastolic murmur. And they have a right heart failure. Why are they coughing? Why are they having hemoptysis? In mitral valve stenosis. Thank you. Because when you have mitral valve stenosis, pulmonary veins cannot empty. And if it lingers for a long time, then the pulmonary veins, capillaries start getting congested. They can't empty anymore. They begin to rupture. And when they rupture, the patient begin to cough up blood. Okay? So that's why they get hoarseness. And then, why do they get chronic cough? Because when you have mitral stenosis, the left atrium gets big. And when the left atrium gets big, it begins to irritate the recurrent laryngeal nerve behind it. And the recurrent laryngeal nerve will cause chronic cough and will make their voice hoarse. Okay? Alright? Extremely important. Anytime you have non-cardiac symptoms associated with cardiac conditions, you want to know them, all of them. Okay? So, mitral valve stenosis gives you hemoptysis, but aortic stenosis gives you GIB. Remember? Yeah, make that difference. It's extremely important because I will test that. Okay? Good. And then again, diagnosis, same old, EKG, echo, cardiac cath. How do you treat it? Pay attention, because this is on the left side, this is mitral valve. They are at risk for atrial fibrillation. You have to treat atrial fibrillation. This is just to tell you, yeah, you got to treat atrial fibrillation. We have a whole class on arrhythmias, so just know that. Indication for intervention, again, symptomatic patient, or when there is systolic pulmonary pressure more than 50. And what do? You can do balloon, because it's stenosis. Remember, in all of them, all stenosis, balloon is always an option. In regurgitation, it's always replacement. Okay. And this is mitral valve regurgitation. You see the causes of it? Mitral valve prolapse. No, it's too much. I think I should stop. Yeah, because we still have like 10 slides, right? Yeah, I don't want to know. It is important that you understand this. What I'll do is, hey, next Monday is a holiday, so it's okay to drag you now. Yeah, let's go on. What do you want? You want to come on Monday? All right, so you cannot take both ways. I'll stop. Before the next class on rhythm and stuff, maybe we will start like 7:30. Is that okay? No? Yeah. Or you stay till 11:30 also at that time? Yeah. I think what happened, I don't know what happened. I don't know. I think no, 7. Everybody is not comfortable with 7:30, but I think everybody can do 11:30. So we start at a normal time, and I will. I may or may not need to extend till 11:30, but these lectures are very important. It's not a whole lot of slides left. I think how many slides? 12. No, that's a lot. All right. So we will continue with. I was continue with mitral valve prolapse. Did I finish talking about this?
No.
So let me just use 3 minutes to wrap up on this one. Or should I stop now?
Yeah.
Okay. We'll finish this in about 15 minutes before we start our next lecture. I'll take your question at that time.
That's what the chunker. I don't like that guy.